Shirley. Dr. Mbokosi. Professor Mbokosi, please. Okay. It's written there. It's our future professor. What you like. Good afternoon once again. I'm Vincent Adeni. I'm the head of clinical unit for family medicine at Sisulu Makiwani Hospital. And I'm one of the clinician scientists with iYunivesithi. I'll be sharing this session. And we are going to move very fast because our session is actually going to be showcasing the best that we have in terms of innovation from the Faculty of Medicine and Health Sciences. We'll be a little bit very strict with time because we want everybody to be able to tell us what are the key messages of their presentation. And I will want to encourage our colleagues to go straight to the points of the presentation so that we are able to appreciate the innovations within the presentation itself. And there will be enough time for us to engage the presenters at the end of the presentation. The first presenter for this afternoon is a very dear friend. We call him, I had a brief chat with him before the session. He said I should introduce him as one of the leading lights, from Pondoland. He's a vascular surgeon and is the only one from the entire eastern to the central region. And it's my pleasure to invite Dr. Lungisani Timba to talk to us about bifem inferior vena cava bypass post-stenting failure for non-healing leg ulcers. Thank you.
Thank you very much for a nice introduction. First of all, let me greet the House at large on all protocols are observed. Everyone is so important. Is recognized and is greeted dearly by Dr. Mtimba. I'm going to talk about a case that I did in my unit, but probably before I do that, I need probably to introduce what is vascular surgery, what is vascular, and where do I point? Okay, back. Okay, yes. Okay, I just came up with those questions. What this thing is all about? What is vascular and endovascular surgery? It's all about. It is mainly dealing with all the problems that are pertaining to blood vessels, arteries, veins, and lymphatics. Every issue that has to do with that is either it is occluded, or it is not working well, or whatever, it's aneurysmal or anything, it is treated by this unit. It's called vascular and endovascular unit. The biggest challenge that we face as vascular surgeon, it is the increasing prevalence of peripheral arterial diseases. It is reported that in normal population, it is about 10 to 20%, depends where you're coming from, depends on so many other factors. But what has been noticed is that as you grow, the incidence or the prevalence also is growing. It is found that when you are about 50 years and above, the incidence is almost tripled. It is related to so many factors. I'm going to talk about them today. That is mainly the peripheral arterial disease. The issue with it is that it is due to atherosclerosis, and unfortunately atherosclerosis, once it presents in one vessel, it simply means that almost all the other vessels, all the vascular beds of the body are also involved. And it is associated with very high limb loss, amputation. It is also associated with a very high death rate because even major vessels like your coronary vessels, your brain vessels they get to be involved. So what you see presenting to a vascular surgeon, it is just the tip of an iceberg. The actual ice is under the water. This is all what vascular surgery is all about. So we're dealing with those, and it is quite common. My unit, which was started in 2021, in 2020 when I returned back from training, we mainly seeing the eastern and the northern part of the Eastern Cape. As you will know that there are only, for the longest time before, I was forced to go to school by Dr. Madiba and our former CEO. They said, Mtimba, go and do this thing, Mrs. Magwetin. I said, but Dr. Madiba, I'm busy. Mtimba, go and do this thing. Dr. Madiba begged me for about 3 years before I decided. And I'm like, hey, Dr. Madiba doesn't want to give me a break. But the issue that he was seeing at that time, he was our clinical governance with Mrs. Magwetin, who was our CEO at that time. Our patient will be having a tissue loss, which is something that's supposed to be sorted within a week. Then you will get a review date in PE, which at that time was the only functional unit in the Eastern Cape. They will say, bring your patient in 6 months' time. And the time the patient will end up with general surgical care, we all know what it is. It is mainly amputation. And then we were amputating our patient, they were dying on our hands. But then, because of such great ideas, I eventually decided to go. Then in 2021, I came back. I didn't know where to start. The actual unit is full of so many things. It is a very expensive unit to run. But I don't want to lie, the kind of support I received from the Department of Health, from Nelson Mandela, the people who sent me, and to a certain extent in the university, it was too big. As we speak, we're seeing more than 110-something patients per month only on vascular, and we operate on more than close to 100 patients a month. We are doing great things, I'm telling you. Now, as we speak, there is about, the biggest thing that is happening is trying to establish the unit. The burden of disease is too big. It makes everything to be so difficult. Most of the time, you hardly find us in meetings like this where we sit down, because if we speak, someone is bleeding from somewhere, someone is having severe pain somewhere, I have to attend to that. So it is such a busy discipline, and it needs a lot of support. Now we are trying to academize it, to make it academic with the help of the university. We want to also train, because the experience that we got from our seniors is that if you want to keep anyone in Mthatha, don't take this person from East London, because we will not survive in Mthatha. You don't take anyone from Cape Town or these big cities, because they will not survive. Very few will really survive. It's the likes of Prof. Mukhacha, but most people do not survive. We don't know why, but the strategy to that is that we must make our own. That is what we are trying to do now. We're trying to make it academic and make it functional, and make more people from locals, people who can confidently stay in Mthatha and that we can count on. It's a very lucrative discipline in so many ways. Once you do it, you're stuck with it. So we need someone that will definitely be like that. When it comes to the research output, it's a big problem, because when I was trying to look what is the prevalence of peripheral arterial disease in the East, in South Africa, they was like told that there's no really known data about this country. Instead, they elaborated from what is going on the worldwide. So that is to say to you, there's a very big area for research. We need a lot of contributions from the university. We need structural support that will make research easy, because it looks like it's a raw area that we need to research a lot. As we speak, I think there are about 3 papers that are online. One, the results are already there, but you just need to sit and write manuscript. So this is what we want. This is where we want to see ourselves as vascular. We also do veins. Today I decided to just choose one patient that I've treated in Nelson Mandela. This is a patient that I wish I could have chosen you, Dr. Matiba. No, I couldn't. I couldn't choose you. I will tell you my reasons. But this one is a very young lady, 37 years old, who has been having leg ulcers that were very painful. She couldn't work, she couldn't do anything. She is someone who was having ulcers since 2009 at the age of 24, 25. She was very young. And then this patient was referred from the northern part of the Eastern Cape to us. And when she came to us, this is just a summary. She had these terrible ulcers. I think let me show you there. They were like everywhere in the legs. She couldn't do anything. She lost her relationships. She couldn't keep a single man around her. She has got no kids as a result. Maybe once I successfully treated this patient, I must refer to Dr. Mpumlwana so that she can help him. She is smelling, according to herself, when she's sleeping. The sheets, if you put on white sheets, there are stains in the following day. And then this patient was initially seen in Cape Town, one of the vascular units. There's about 2 vascular units in Cape Town. There's 2 in Eastern Cape now. Eastern Cape is progressing. There's 3 in Gauteng, and there's 1 in KwaZulu-Natal. The rest of the other provinces do not own any vascular unit. As I'm trying to show you how important is this for our patient. This patient was treated severely in our unit. Initially in 2017, she was treated in Cape Town in 2017. I don't know, see where is that? Where she was put stents because she had these ulcers. And then she was better for only 3 years. Then she came down to Eastern Cape. Then when she was there in Eastern Cape, the ulcers came back. And then she came into my clinic in 2022. I opened in 2020. And then I've been trying to avoid the major operation. But she kept saying, Dr. Mtimba, I only trust you. I have no other hope. And she's from Eastern Cape. Then now I sit down and ask what to do next. Then the first thing, I started to investigate her. I wish that was working, but what it shows is that the stenting that they did in Cape Town starts just below the renal veins, all the way to the legs. It's all occluded. There was nothing we could do. And then, I sat down with her, discussed what to do. I don't know whether it's coming out nicely there. But you can see there's a metallic wire from that point all the way to the leg. This was not done by me, but I also do that in Cape Town. But now it's blocked. Took her to cath lab. We have a cath lab in Nelson Mandela. It's fully functional. It's very helpful. Unfortunately, when I got there, come from all different angles. There was no way I could go through the wires so that I can try and remove that part. I struggled a lot. And then I had to sit down and say, then in this case, I have to do an open procedure. Then I took her to theater. In theater, I had to go into the leg and then into the abdomen, into the abdomen. From the abdomen, I used this material. This material is a bovine cow, it's a cow carotid. This material, it's very expensive, and then I can't afford it. We took blood from the legs, both sides, all the way into the renal vein. And then this patient, as we speak, we could compare the ulcers in 2 weeks. The ulcers shrink significantly. As we speak, I couldn't get hold of her because the ulcers have disappeared. I hope she won't come back. This is how far we're doing in Nelson Mandela. We are very happy with the support we're getting from the province, from the actual hospital procurement department. Sometimes you have to hustle a little bit, but things they do get happen. We are very grateful. Thank you very much. We hope that soon I'll be having a colleague from me. Thank you very much.
Thanks very much, Dr. Timba, for the excellent presentation. That's my father there. I can't say no. Dr. Madiba, can we? Yes. Can you pass the mic? Let's give exception for Dr. Madiba, but otherwise, every other comments will come after at the end of the whole section. Yes. Okay.
Yeah, because it will fade. Remember, we're old enough now. Things start fading. Thank you so much. Basically, Betuna is a testimony of what Mtimba did. I had a wound which was dressed almost 3 times a week. And the wound was old as 8 years. And nobody could cure that wound. I've been to PE, I've been all over the show. And ultimately, Mtimba, when he came back, he said to me, Madiba, let me attend to this wound. You might think that I'm lying. For the wound to shrink and to be fine, it took him 2 weeks, and the wound was disappeared. You could see I've got nothing now. You can come and have a look if you don't believe. Nothing. Thank you, Mr. Mtimba. Thank you, sir.
Yeah, thanks very much. I was going to say there is power in case reports. So Dr. Mtimba identified a structural gap in terms of the support for research in his units. So there is a very brilliant gentleman here I want to introduce him to. Where is Dr. John? Jeff, just wave, okay? If you want to publish single paper based on single individual case report, I would recommend Dr. John because I know what he is doing in East London. That would be a good way to start. As you then have larger number of patients, then you can have opportunity to do bigger studies. That would be my recommendation to you. We have just been informed that dinner will be served at 6 p.m. Please, we want all the members of the audience to be part of that. So we don't want people leaving until the end of the program. We are going to move swiftly and permit me to make adjustment to the order of the presentation. One of the presenter needs to be part of college assignment at 2 o'clock. So the second person I will bring on stage is a very good colleague of mine. We have known him for 3 decades now. We came to study in Umtata. We were both recruited by Madiba in 2010. And we are still here in Eastern Cape, sir. Yes, so he's going to come and talk to us about innovations in medical education. He's going to highlight our COBIS, our ILCC for the students and the rural clinical school, how it's impacting service delivery across the province. It's my pleasure to invite Prof. Adeleke to come and give us his talk.
Thank you, and good afternoon, everyone. I think I must first make a disclaimer. I'm not claiming any original work here. I'm just here to report the great work and the good work that has been done by those before us. We've got Prof. Fenyana here and others who have done a great job. So I'm just here to report on what they've done. I think it's quite exciting to talk about artificial intelligence and the future it gives. But we must remember that medicine is essentially a human profession that is rooted in compassion, in trust, and in social accountability. In all this excitement about AI, vascular surgery, everything, we must remember the most important person is the human touch that we must not lose. So in the next few minutes, I will try to share with you how we've tried to train doctors. How do you move? Okay. How we've trained doctors not only to diagnose disease, but to treat the person, heal communities, and serve where they are most needed. I'll first of all show us the systemic disconnect that perhaps was the basis for the medical school here in the Eastern Cape. Traditionally and historically, medical training was usually centralized in tertiary hospitals, but we all know that most care are needed in primary health care, district hospital, regional hospitals, yet we centralize our training in tertiary hospitals only. We also put a lot of emphasis on specialized facilities, equipment and all of that. Well and good, but majority of people, majority of the needs are actually in the community. I don't know where to put that. Okay. Then, historically, most of the training were mostly about tertiary training with minimal focus on healthcare, on primary healthcare exposure. And we know that the most need of the people is primary care. So this slide is just to show the reality that we have on ground and the historical training model that was implemented in the country, and the disconnect between what we're training and what the community actually needs. Now, at Sisulu, we thought about this disconnect and we decided deliberately to take a different path from what is known generally. Instead of just basing our training in tertiary hospitals only in big cities, we took our training to primary health centers, smaller cities, rural areas where the bulk of the population reside, where the bulk of the need are. Instead of focusing our training on diseases, what we call a disease-centric training, at Sisulu, we took a deliberate effort to make the person the center of our training. So by so doing, we respond appropriately to national burden of diseases. Historically, in other universities, when their student graduates, they wish to work in big cities, and they are reluctant to go to rural areas and remote places. At Sisulu, we took a deliberate decision that our training, we prepare our students for them to be able to work everywhere, locally, in rural area, nationally, internationally. They're able to cope anywhere you place them. So we are producing a unique type of doctors. To do this, we rethought the focus of training. We took our training from big tertiary centers and we took it to the community. Of course, we still train in tertiary centers, but we've added regional hospitals, district hospitals, community health centers, primary health centers, the home. We go to people's home, actually, so that we are actually where the most needs, the people need us the most. This is where we train our students. We train students in tertiary and regional hospitals, district hospital, community health centers, primary health centers, and even homes. This is to show that what I'm saying is not a fairy tale. You can see our students going to various primary health centers. You see our students in large tertiary hospitals. You can see our students in the community, and you can see our students in patient home. This is a unique way, and this is our innovation at Sisulu. We're taking training to where healthcare is needed the most, to produce authentic doctors who are able to work everywhere they are needed. There is a quote which is very popular, that medical education is only relevant if it is responsive and is relevant to local needs. Hence, our faculty motto is excellence through relevance. And how do we do this? First, the first thing that the university offers, our faculty offer, is access to previously disadvantaged students. We prioritize students from disadvantaged background and we give them a chance at becoming doctors. Our context of training is also unique. We train where the need is the most, including tertiary hospitals, district hospitals, and primary health care. And the outcome is that our students are ready to work anywhere they are needed, rural, local, national, and international. Now, we have a community community-based education, and a socially responsive medical education. These are the pillars of our medical training at Sisulu. You see that the first thing there is collaborative partnership, which is illustrated by our being here today. We partner with Department of Health, with community. So partnership is the strength of our program. We also integrate service learning into our program. Our students serve while they learn, and they learn while they serve. As I showed in the previous slide, we have a distributed clinical training platform spanning the whole province and including all levels of care, from tertiary to regional to primary and to CHCs. And of course, we engage in community engaged scholarship, and our program is aligned with provincial and national health priorities. Now, I will take us quickly through the journey of a medical student at Sisulu. In the first 3 years, our students are exposed early to community and to the healthcare system. From the very first year of training, our students get introduced to the community and to the health system from the first year, and that continues throughout their training at the university. I will go through some of them more in details. In the first year of training, our students spend about 2 weeks being introduced to the community and the health system. And what we have done is we introduce them to both the Western medicine and also to alternative approach, our indigenous health system. So our students get introduced very early to the health system. They visit community clinics, they go to schools, they participate in nutritional program, and they also engage with traditional healers. This gives them a very broad view of what medicine is all about from the very first year of training. In their second year and third year, we have what we call COBES, which is Community-Based Education and Service. This is for MBCHB 2 and 3. At the second year, our students they are placed in district hospital for 3 weeks, where they get introduced to what the healthcare system is all about. They are able to understand how do you refer upward and how do you refer downward. They are able to link what they've learned in the skills lab to real-life situation. This provides the student with an early understanding of how the healthcare system functions. This team continues to their third year, where they do what we call COBES 2. Here, we expose them to a deeper understanding of community health challenges and research, to understanding of local health priorities. So what happened in third year is that students in a group of 10 to 12 goes to a CHC every week for the entire year. And they are also exposed early to how to do research and how to understand health priorities of their community. And this is our effort to make our students to be socially accountable and responsive to the need of the rural communities. Our next program is what we call the ILCC, which stands for Integrated Longitudinal Community Clerkship. This was introduced in 2014, and we do this in MBCHB 5. What is this all about? This is on the right side of the slide. It will be your left side. You will see the traditional curriculum, where all disciplines are in silos. You do medicine 6 weeks, then you go to surgery 6 weeks, like that. Then students used to learn in isolated silos of short blocks of only 6 weeks, and this put in their mind a fragmented understanding of patient care. What ILCC does is that it brings everything together. It integrates the training. They no longer learn in silos, but they're able to integrate all the learning, all the discipline at the same time. Okay. Oh, okay. Now, what are the elements of ILCC? Our students participate in patient care for the duration of their posting in district hospitals. Because they stay in this hospital for 20 continuous weeks, they become members of the healthcare team. Everybody, they become part of the team. They work with doctors, with nurses, with all healthcare workers, and they become part of the team. And they learn how to work as a member of the team. And importantly, they gain clinical competence across multiple disciplines at the same time. A woman is pregnant, has got a fracture, has got a TB, and is HIV positive. They're able to manage that woman comprehensively and holistically, not just thinking of O&G, internal medicine, and orthopedics. And more importantly, this is where our students learn ethical practice and professional identity. This is where they develop into real doctors, not just people that know medicine, surgery, or O&G. Our footprint is quite wide. We are in every part of the province. Currently, we are in 16 hospitals, in 5 of the 6 districts, and in 1 of the 2 metros. Our students, like I mentioned, for this program, spend continuous 20 weeks at the same hospital. And I must say, we are the first to introduce such a program in the country. What people call ILCC in other places is they send students for 2 weeks, for 3 weeks. We took the chance, we took the bold step to place our students for a continuous period of 20 weeks. And this has become, we have been known for this, and we know that other schools are actually trying to copy us. So if you go to any hospital these days, you will find our product there, who did their ILCC in similar settings, who are comfortable to work in similar settings. They are ComServe now, they are doctors now, they are medical officers. They were trained there, so they are comfortable to keep working there. So ILCC offers continuity of care, continuity of supervision, continuity of learning, continuity of community engagement. This is the strength of this unique program that we innovated at Sisulu University. The last innovation, which was talked about yesterday, is the rural clinical school. And the question would be, why do we need a rural clinical school? What is the point of it, since we have ILCC? The basis for having the rural clinical school is to address what we call the inverse care law. What is that? The inverse care law simply states that people who need health care the most have the least access to them. And irony it is, but that is the reality of our lives. People in rural areas and in remote places are the ones that need health care the most. Unfortunately, they are the ones that have the least access to care. Why? Because healthcare practitioners are reluctant to work in rural areas. You post them there, they secure a post, after a year, they leave. Reason is that it has been shown by research that they've not been sufficiently exposed to rural practice during their training. So rural clinical school actually tackled this, where we train our students so that when they graduate, they will be able to work in similar settings. The aim of the rural clinical school is to produce healthcare workers for rural and underserved communities, and we want to increase access across the whole province. And we are utilizing the PHC model to pursue this agenda. The picture there just shows the formal launch of the rural clinical school in February. You can see the vice chancellor, the VC, and the MEC. It's a partnership. The rural clinical school is not a university project. It's a partnership between the university, the community, and the Department of Health. This is the model that we're using for the rural clinical school. It is based at Lusikisiki. We use what we call the spoke and hub model, where the school is based at Lusikisiki, shown in green here, but it's also include all hospitals in that region, including Bambisana Hospital, Greenville Hospital, Holy Cross Hospitals, and Oliver Adeletambo Regional Hospital in Bizana. Not only the hospitals, but even all the clinics in that region. So we are establishing a regional network from the hospital right to the clinics in the whole of the region. So this is an exciting program that has been ongoing. This is the core objective of the rural clinical school. I'm not going to bore you with it, but you can see some of them are quite lofty and they are quite exciting objectives: to improve health outcomes in rural areas, to encourage long-term rural clinical practice, and to enhance healthcare access in rural areas. These are just some of the objectives of the rural clinical school. Now, rural clinical school is not just a dream anymore, as the Honorable MEC mentioned last night. It is now fully functional. Our clinical training started at this school on the 19th of January this year, where we put our first 10 students at this site. They started training on the 19th of January. And on the 4th of February, we had an official launch of the Rural Clinical School at Lusikisiki, attended by all the stakeholders from university, ECDOH, community, and commercial enterprise, and the community as well. So the Rural Clinical School is fully functional and is growing from strength to strength. So, to summarize what I've just presented, this is the journey of our students in terms of how we introduce them to community and how we build a socially accountable medical doctors. In the first year, the 2 weeks of exposure. In the third year, in second year, 3 weeks. In the third year, 7 weeks. In the fourth year, you see I've not put any weeks there. Not that they're not doing that, but the focus in the first year in the fourth year is on the clinical disciplines. But students are still exposed to this community because they participate in outreach with the department they are placed. At the fifth year, we have 20 weeks of ILCC and 4 weeks of family medicine. And in the final year, we have 6 weeks of family medicine, and for those that are placed at Lusikisiki for Rural Clinical School, additional 44 weeks. So this shows the journey in our innovation to produce a socially accountable doctors. So this is just a summary of what I've just presented earlier, taking us through the journey from the first year right to the 6th year in terms of our medical education. This is still saying the same thing in various ways to just show that out of the 124 weeks of training, our students have 42 weeks of clinical training in the community. However, for those in the Rural Clinical School, this percentage of training in the community is as high as 70%. I think that is a huge achievement in terms of community-based education and socially responsive doctors. So who benefits from this innovation that I've been talking about? It's a win-win for everybody. The student benefits, they become clinically competent in both rural and urban healthcare settings. They have a strong understanding of social determinants of health, and they are prepared for local, national, and international practice. The community also benefits because wherever our student goes, resources follows. So there is improved access to healthcare and specialist services in all our facilities where our students are placed. And this innovation also strengthens district and rural health system. Of course, it leads to improved healthcare quality and health outcomes. Now, the Department of Health also benefits because this innovation improves district hospitals' service delivery and clinical governance. It improves staff recruitment and retention, and it aligns medical education with provincial health priorities. Of course, wherever our student goes, there is training, there is development. It leads to staff development through specialist outreach and mentorship. And as a university, we also benefit, of course, because this enhances partnership with community and health systems. So, what's the outcome of this program? We produce future-ready graduates through COBES, ILCC, and Rural Clinical School. What I solely produce a unique type of health professional who are holistic practitioners. They are equipped to work in complex, even resource-constrained environments. They are patient-centric. At the heart of their practice is the patient, which I think we mustn't lose touch of in medicine. And lastly, our graduates are socially accountable. They are prepared, they are willing, and they are competent to serve in marginalized communities. Indeed, we are relevant, we are excellent through our relevance. So in conclusion, colleagues, by our training and integrating students into the community from the early years through to their final years, we prepare doctors to serve where they are most needed. We foster a more equitable future for healthcare. I thank you.
Thanks very much, Prof. Adeleke. I think you've used half of another presenter's time. So we'll move very swiftly to the next presenter, Dr. Prof. Apalata. Prof. Apalata needs no introduction to most of the people in the room. He is the chair of our research innovation and is the deputy associate dean for research and innovation for the faculty as well. And he holds a lot of other portfolios. Without further ado, please come forward and give us your talk. Thank you.
Thank you, Chair. And good afternoon, everyone, all protocol observed. Can I have the presentation, please? I'm going to report on the stride of our postgraduate research and and the innovation in the faculty. Thank you. All right, so this is what the report will be about, stride in postgraduate research and the innovation in the faculty. This is the presentation outline. I will start with growth in postgraduate program and our throughput rate. As you can see, we have managed to expand on a lot of programs in the faculty, ranging from various programs in the School of Biomedical Sciences, School of Pathology, School of Public Health, the Department of Nursing, and we have various MEd program in clinical disciplines. And as you know, we also have the PhD program in health sciences. So we had about 23 specialist training program, the MEd, and we just phased out the generic MEd. So we have 22 fully accredited program in the faculty for specialist training. And we are working on new programs, mainly the Master of Medicine in Medical Microbiology that is under review currently. We are developing postgraduate diploma program in nursing. We are working on 5 disciplines there, and the BSc honors in medical anatomy. So those are the new program that you can expect. The enrollment in the faculty has substantially increased over the years. Last year we reached almost 699 postgraduate students in various programs. And this year we had a slight decline due to several reasons, registration issues, and also our basic science student accommodation issues, funding issues that lead to that decline that we can see. I spoke about the PhD program. This year we have about 53 candidates registered for PhD. And the other thing we managed to do is actually to achieve a very high throughput rate in terms of productivity for our postgraduate student. We have substantially increased, as you can see, if you compare from our baseline data that we had in 2024 last year and the May graduation this year, where we really achieved a very high throughput rate, over 100 postgraduate students graduated in May. And out of those, we have about 20 specialists who graduated in May. This is the list of candidate disciplines that produce this throughput in May. And we managed to have our first pathologist specializing in chemical pathology, Dr. Sifuba, who also graduated in May. So this is the first time that our faculty is producing a pathologist. We also, for the very first time in one single graduation ceremony, produced 8 PhD. And something very specific about this is that in this group, we can see, for example, we have our faculty administrator who is there, who managed to move and complete a PhD in health sciences. That is a very excellent achievement. And we have 2 of the candidates here. We have Zanele Nomachila, we have Dr. Mbongozi, our gynecologist. Where is him? So what is specific about those 2 is that we started a few years ago our joint PhD program with a UK university called the University of Stirling in Scotland. So we developed a co-title program between the 2 universities. And this is the first group of doctorate candidates that we are graduating between the 2 universities. So in May, they graduated here in Umtata. Then in June, we are traveling with them to go and graduate again there at the University of Stirling. So it's the first time this is happening. And then, of course, we already started preparing the September list. So far, it's still early, but we already have 11 candidates that are recommended to Senate for graduation, and out of 11, we have 9 specialists who will graduate in September, but the list will continue. Now, when it comes to research, research productivity and output in the faculty, what we put together is that we have now various research groups in the faculty, research platforms, research centers, research institutes that have been established. And those have been clustered or classified in 5 major clusters. We have centers that are operating in the area of infectious diseases, non-communicable diseases, cancer and specialized care, health systems and policies, community and health education. Then we have a coordinating hub that is a center that we put in place that we call CRADL, and that I will talk a bit on that later. Then if you see our research output, the way we grew our research output, really from a baseline of 41 research output unit in 2023, we managed to increase by 50% in 2024. Then we went more than 160% increase last year to achieve 167 research output units. So this is really an exponential growth in our research productivity. And this year, within the past 5 months, we have produced 95 research outputs already. And when you see the contribution, we have our staff that is contributing almost half of this productivity. Then we have our postdoctorate research fellows that we hired, about 15 of them from the beginning. And we have high productivity from the postgraduate student. So this has been a strategy that we use to introduce whether the MEd or honors or masters by publication, and it had contributed in the increase of the research output. The other thing is that beside the fact that we increase our research productivity by almost over 160% in the past 2 years or so, we also doubled our research revenue from external grant in the past 2 years as well. We have increased in a modest number the number of NRF-rated researchers in the faculty. This is an area where we need to do more work to increase the number of NRF research rated. But we also need to say that we have increased the number of staff with PhD, moving from around 30 2 years ago to around 50 as we are sitting currently, staff in the faculty who are holding PhD degrees. Last year, we have obtained several research awards and recognitions. The list is very long, and it's a result of the quality of the work that we have been doing. And some of them are like the VC Vice Chancellor's Award by our staff. Out of the 4 awards, 3 came to the Faculty of Medicine. And we have also our colleague there who received another award in terms of pre-commercialization of his product. I think he's going to talk about it. For the very first time in the history of this university, the Faculty of Medicine and Health Sciences had 2 Saki Chair Award winners. So the DST NRF Saki Chairs. So we have Professor Rusike and Professor Nke, who won the DST NRF Saki Chair, and we are going to define our strategy around research productivity with them for the next years. We have also done a lot of work in terms of innovation in the faculty and translational research. We have high number of innovative products in different areas, in the area of diagnostics, rapid diagnostics, in the area of new treatment, development of new drugs, but also in the development of medical devices. We have been doing a lot of work in the area of innovation. I will pick on some few examples, like in pediatric prosthetics development. Some of you heard about this. Our Department of Rehabilitation Medicine has been fantastic in developing these different types of prosthetics. We also put together a product that we call the Manisaple that is used for diabetic foot ulcer. It is tremendous. It's decreasing the rate of amputations. And one of our PhD students has been working, applying what we call the biophotonics technology to develop a new point-of-care diagnostic test for tuberculosis. And we have been working also in the area of anti-TB drug development. And a lot of other devices in terms of emergency obstetrics have been put in place. Now, this is probably the future. It's a study that we call Precise TB study that is going to use data from, it's going to combine, we are developing a machine learning algorithm that is artificial intelligence, where we train those algorithms on genomics data from whole genome sequencing of Mycobacterium tuberculosis with clinical information and geographical information where the patient is coming from and all that previous exposure to TB treatment and so on to try to predict anti-TB drug resistance profile. So at the first time that you will meet with the patient, you will be able to put this patient on an appropriate anti-TB treatment. And this will reduce the time and reduce spread of infection in the community. All right, so capacity building and mentorship has been at the basis, has been central to the work that we do. And the first thing that we managed to put in place to make all this possible is the establishment of the Center for Clinical Research Advancement, Development, Leadership, and Education. And through this center, we have been doing a lot of work, capacity building, supporting registrar in terms of their research projects, facilitating procurement processes, managing grants, research grants to avoid delays. So, and we have organized several boot camps to support postgraduate students complete their work on time. And also we have supported a lot of writing retreats for publications and so on. That's why you see all the changes that you can see in terms of research productivity. Now, we also managed to build a very large strategic partnerships in South Africa, in Africa, and across the world. You can see almost in all sharing of resources in terms of joint supervision. And the example of this is the University of Stirling, where we did set up our joint PhD program. Then those are the outcomes and so on that we have achieved. But we have key challenges, and some of them, it's mainly around research infrastructure that we are now need to start thinking how we can build our research infrastructure, and we also need to improve in terms of grant applications so that we can be able to attract a lot of funding to achieve what we are going to achieve with the vision that we have. So there are many things that we plan to do in the future. But first thing first is that one of the things that we want to do is especially to try to optimize or harmonize all the academic ranking across the platform, especially for all joint staff establishment colleagues, to assure that they got appropriate academic ranking with the university so that they have access to all academic facilities and advantages to try to continue to build our research.
Thanks very much, Chair of the. Thanks very much, Chair of the Research and Innovation Committee. And definitely we can see the growth that we are having in the faculty. And the testament to that, reflected on the awards that were taken by our colleagues from the faculty. Without wasting any further time, I will proceed to the next presenter. Dr. Kokose is an ENT surgeon whose interest is in cochlear implant, and is going to be taking us through innovations in terms of, the Nelson Mandela Academic Hospital Cochlear Implant Program. You are welcome to come and give us your talk. Thank you.
Thank you. Okay, good afternoon. Sorry. Okay, so I'm just going to give you a brief overview of the Nelson Mandela Academic Cochlear Implant Clinic that was started in 2018. So just little facts about hearing care in Africa. Globally, hearing loss is on the rise, and about 80% of affected individuals actually live in middle and low-income countries. The WHO reported in 2023 that 40 million people with hearing loss are in Africa. And they estimate that by 2030, that number is going to rise to 54 and about 97 million by 2050. Fortunately, 60% of causes of hearing loss are preventable. And if you look at costs in Africa, hearing loss, costs economy is about 27.1 billion USDs. And very worryingly is in 88% of countries, they have less than 5 ENTs, ENT surgeons. In 93% of countries, they have less than 5 audiologists. And in about 86% of countries, they have less than 5 speech and language therapists. All these professionals are important in hearing care. And majority of hearing, disabling hearing, can be treated with just a simple hearing aid, which is far less expensive compared to a cochlear implant. And it has been found that only 47% of countries offer ear health care at primary care level. So the picture you see there, that's an audiogram. That's what we use to classify hearing loss. But in general, there are 2 types. It's either you're hard of hearing or you're deaf. Individuals that are hard of hearing, they usually communicate through spoken language and can benefit from hearing aids, cochlear implants, and other assistive devices. Unfortunately, one paper that was done by Ndwandwe in 2025, they found that learners who are hard of hearing in the Eastern Cape are actually taken to schools for the deaf. Now, deafness is profound hearing loss. There's very little or no hearing. Some may benefit now from cochlear implants, auditory brainstem implants, but some individuals actually need to use other forms of communication like sign language. Now, the issue with hearing loss in newborns is this phenomenon of auditory plasticity. So what happens with the neural connections in the brain, they continuously need sensory input. So if a child is born without hearing loss, then they lose that connection. Usually we have a limited period to put an implant or a hearing aid, and it's up to 3 years of age. Unfortunately, we see kids around 3 to 5 years, and they're already out of criteria now for a cochlear implant. So unfortunately, those children, they have to go for sign language. This is I'm not going to go through it, but this is a criteria we use to select people that are going to benefit for a cochlear implant. Meningitis is very common, both kids and adults, and it's very tricky to manage hearing loss in meningitis patients. And the recommendations are those individuals must be fitted with 2 cochlear implants. But unfortunately, the government can only afford 1 per patient. So cochlear implant team is a team that is not just having ENT. There are other professionals we work with, but the core professionals is going to be the ENT surgeon, the one that's going to do the operation. Audiologists, speech and language therapists, those 2 professionals are very important after we have done the implant. Our job is easy. We take about 2 hours, we do the implant, but the patient is going to be a lifelong patient for an audiologist and speech language therapist. And then we also need a clinical coordinator. It's usually our audiologist. Another important discipline is radiology. I've highlighted red MRI there because we have repeated interruptions of MRI, and they're very important in assessing candidacy for cochlear implant. Okay, so there's a video there, but I don't think it's gonna play. But this is what a cochlear implant looks like. I don't know if. Okay, so what we have here is a speech processor. We call this one behind the ear and off the ear. So it has a microphone. It's going to take the sound, change it to a digital information, transmit it now to the implant, which is this whitish thing here. So we implant it under the skin, and then we go and find the inner ear or the cochlea, and then we just insert an electrode. So what happens, the sound, the digital information will be transmitted, sent to a speech process, receiver stimulator, and then converted to an electrical information, and then that's what's going to stimulate now the cochlear nerve in the cochlea. Not the whole cochlea is going to be stimulated. It's going to be specific sites in that cochlear duct based on the sound. So it means we actually hear with the brain, not the ear. So in Nelson Mandela, the Cochlear Implant Clinic actually caters for central and eastern corridors of the Eastern Cape. We provide specialized pediatric and adult otology, speech and language therapy, and a comprehensive audiological evaluation. We also have a socio-economic mandate by restoring hearing that directly prevents developmental delays, it fosters school mainstreaming, and breaks lifelong poverty cycles. So this is a cohort of patients we have actually implanted from November 2018. What you see there at the bottom is the total number of implants we've actually used on about 64 patients. It means about 6 of the patients actually have bilateral implants, and none of our public patients have bilateral implants. All of our bilateral implants are private patients, so we cater for both public and private. We also have a rehabilitation school in Nelson Mandela. It has 2 fully employed oral rehab educators that are employed by the Department of Health. They also have 2 assistants, those ones are privately funded. Currently, it has about 14 kids. 11 of them are cochlear implant users, and 3 are hearing aid users. Usually, kids that we think will benefit from a cochlear implant, we send them to that school, and they get assessed. Usually, it takes about 3 months to assess an individual for a cochlear implant in most cases. And once those kids now graduate, we usually we send them to Mandela Park Primary School because we want them to be in mainstream school at the end. So that school caters for kids with hearing loss, but they only use oral language as a mode of communication. It starts from grade R to grade 7. Currently, it has about 8 cochlear implant kids that are attending. Operational bottlenecks, severe surgical backlog. I'm sure everyone is having this issue. Unfortunately, we need a dedicated cochlear implant slate, and it's not looking good so far. Hopefully, in the near future, we're gonna have one. Secondly, MRI service interruptions. We haven't been having an MRI for almost a year now, I think. And unfortunately, we cannot implant anyone without cross-sectional imaging. And underdeveloped neonatal screening program. So what we need, dedicated CI slate. Unfortunately, hopefully, hospital management, Department of Health can assist. Because of our MRI issues, we've actually approached our private hospitals to assist us with imaging at least kids. And we also sourced some funding from other companies to just help us pay for those services privately. And also primary auto-acoustic emission screen. It's something very affordable and very easy to use, especially in neonates. I think if we can offer every primary healthcare facility an OAE machine, so that when a child is born, they just test the ears. You don't need to be an audiologist, so that those kids can just be referred to us immediately. Okay, thank you.
Thanks very, very much, Dr. Kokose, for the good work you're doing, and you kept to time, so that's quite efficient on your part. The next presenter is a very dear colleague whom we have worked with very closely. Is the head of clinical unit for surgery. He's actually the one that revitalized Department of Surgery in Sisulu Hospital. And he's actually interested in looking at cost-effective way of improving trauma care in the entire region. It's my pleasure to invite Dr. Jayakrishnan to come and give us his talk.
Thank you, Vincent. Good afternoon, everyone. I always thought that physicians are storytellers, but it looks like today we surgeons have also developed a penchant for storytelling. So, no, that's not mine. That's not mine. Okay, sorry for the glitch. So I stand here wearing two caps today. I'm representing the Global Surgery, Center for Global Surgery of Sisulu University, and I'm also the Medical Director for Primary Trauma Care Foundation based in the UK. As I mentioned, you listened to a pediatric surgeon story. Now it's an adult surgeon's turn. Nothing very much adult about it. I'm going to share a journey that started in Umtata and transcended the borders of Eastern Cape and address one of the very important inadequacies in our healthcare system. So this is about trauma and injury. I will start with a snapshot of global trauma. More than 5 million people die from trauma globally every year. And if you look at that number, that is more than malaria, TB, HIV, and COVID-19 all combined. So that is the number that you are looking at. And if you are in a low or middle income country, you have 6 times higher chances of dying from trauma for the same injury as opposed to if you are in Western world. And trauma is considered to be the #1 killer in the age group 5 to 30 globally. And the majority of population, especially in low middle income country, more than 60% of the population is 15 to 13 and therefore victims to trauma. Now, is there a case for trauma training? What is the impact of cost versus outcome? So there is a good quality evidence stating that training for trauma or empowering healthcare workers for trauma management gives a very good output. More than 50% of the deaths will be preventable if you provide adequate trauma care for healthcare professionals. And you can prevent 1/3 of the disability in low resource settings if you provide adequate trauma training. So now, if you look at locally, where are we standing in Eastern Cape? If you look at the sheer number of trauma, we had close to 10,000 trauma deaths happening in 2021, according to the Statistics South Africa, which was released in 2023. But if you look at the population, we are not #3, we are #2. So that is how bad we are affected as a province. So there's definitely a case for looking at trauma care in the province. Now, again, if you split those numbers, 68.6% of those trauma deaths were from accidental injury. And look at the population group that was affected. It is the young people, 15 to 29 age group. And that is 45% of them were males. So again, look at it, 60% were females in that age group. So there's a lot of trauma training modules that is available. Some of them are very popular in South Africa. But now, there are certain inadequacies in some of these trauma courses that is available. One of the issues is it's very expensive for most low middle income country. Even for a doctor, it is becoming unaffordable to do this course repeatedly. So that's one of the major challenges. The second one is it caters to a limited audience. It mostly caters for doctors, not for paramedics, not for emergency care practitioners, not for your nurses. So that's one of the challenges. The third one is it's got a rigid structure. It does not always take the local context, the law resource setting into account. Sometimes it doesn't even take into account the language issues. And the last one, which is very important, is these models are not self-cascading. So you cannot escalate the courses locally. You cannot run the course in a hospital on your own. So these are the major issues with the existing courses, although they are considered to be gold standard. So now here I'm going to introduce to you PTC course, which is otherwise the Primary Trauma Care course. It is a 2-day training course, and we teach healthcare professionals, I'm not referring to doctors, healthcare professionals to manage, to communicate, and also to teach the systemic management of trauma patients. It is offered free to all participants, and it is adapted for the low resource setting. And we use local faculty most of the time. As I said, it's a 2-day course program, and it includes lectures, demonstration scenarios, practical scenarios, skill stations, and discussions. Now, the footprint of primary trauma care is global. The latest entrant from South Africa is Burkina Faso and University of Botswana. From the North American continent, University of California, Davis just now took PTC as a mode of teaching. We are present almost everywhere in the world except Europe. And we are very active in some of those small islands which you can't figure out in this map, like Fiji and Vanuatu. We have partnered with various organizations. For instance, COSEXA uses PTC as a form of training for their registrars. The IMC and Doctors Without Borders offer the course to train people in Gaza, Ukraine, and so on. We have alliances with other organizations like GIGS, the Global Pediatric Group. We help them evolve their pediatric trauma training program. And we are part of the WHO, and we give input in organizations like Acute Care Action Network and GACI and so on. The course is acknowledged by the Royal College of Surgeons of Edinburgh, and CPD certification is offered in conjunction with the college. So there's ample literature around substantiating the value of PTC in low resource setting. I'm not going to go through that in an elaborate fashion. So now here's where my story is actually starting. I'm taking you back 18 years. 2008, PTC was originally brought to Umtata through the effort of an orthopedic surgeon, Dr. Oloran Toba, who is there in blue shirt, standing in the middle. Unfortunately, David is no longer with us. And it was started under the patronage of Professor Lizo Maswai, who was my former boss at that time. And we started off in Umtata. Some 6 or 8 of us were trained as instructors. That includes Professor Dafala, Professor Malo, and so on. And just as we were about to embark on this journey, there was a very strong institutional resistance coming from within the country, asking us not to proceed. So Prof had to negotiate, and we came to the conclusion that that course will be offered only locally in the former Transkei and not beyond the Kai Bridge. So that time we did, I think, 4 or 5 courses locally. But what happened is that we were asked to go and support other countries within Africa. So we flew to many countries as a team, and we supported other countries like Kenya, Tanzania, and I think Zanzibar also. We went to Sudan, and lots of places, and we helped them to initiate trauma care program in those countries. Later, I was invited by the Ministry of China, the Health Division of China, to go and validate a course in one of the poorest provinces, Sunyi, and that's the photo from Sunyi. China had a very rigorous rollout for PTC. They actually imposed it on their doctors. Everybody from the cardiologist to the lowest level had to do the course, and they covered 15,000 doctors over a period of 2 years. So this is where the second part of the journey starts. This is Cecilia Makiwane Hospital in Mdansan, a beautiful platform. And when I came across from Umtata as the head of the department here, I decided to start the course in the central area, and which was actually breaking away from the promise that was given by Prof. Maswai. I did it because I felt there was a sheer need for trauma course being offered to the healthcare professionals, because there's the so-called mismanagement, which is actually happening out of lack of knowledge or lack of experience. So I felt that there was a dire need for this course to be offered to the healthcare professionals. So I called upon my colleagues, senior people like Professor Adene here, and the picture in the middle, that is Dr. Reddy, my right hand in the department. We had Dr. Nogela from anesthesia. We had a discussion, and we decided that we should go ahead and offer the course using CMH as a platform. So subsequent to that, I had to invite some people from the UK also to support us, and we initiated the course in CMH. And this was not an easy task, because although I received some funds in the promise of funds, initially the department backed out and they said halfway through we can support. So there was funds for catering, but there was no fund for accommodation, and everybody was arranged to come here. So that time I had to go and interact with the corporates, and they helped me support with the funding for accommodation. So I'm very grateful for those people who assisted me to launch the first course successfully. You can see the Ms. Jafta, and many others who are present here in this audience. They were there in the first course. So we initiated the first course, and then we used CMH as a hub to train people from elsewhere. And in the first course, we invited paramedics, emergency care practitioners from PE. They came, and they were also trained as instructors. Senior people, they were trained as instructors. Some of them are lecturers in that college, and they formed part of the first unit. Okay. Immediately after that, we were hit by COVID, so there was a transient, difficulty with conducting courses. I carried on with the modular program. That is the other attraction for the course. You don't need to have a 2-day course. You can offer the course as a modular program over a period of 6 to 8 weeks, and that is what I do for my interns in my division. And even for the students, medical students, I take them through the full course over a period of 4 to 6 weeks. And then we initiated the course, that is the EMS college in Gebaha doing the course under the leadership of an EMS practitioner as the course director. Subsequent to that, we did another course in Frontier Hospital where we trained a lot of doctors. And this course was actually done mostly with the help of doctors from Frontier itself. So last year, we resuscitated the program again in Umtata. Over the period, they had not been doing many courses, so we decided to go back because there was a lot of enthusiasm in restarting everything. So we went there and helped them, and you can see the team under the leadership of Professor Molova there, who are trained as instructors. So this is the feedback from the course from last year. We trained a grand total of 77 candidates. That includes 12 nurses, 7 clinical associates, 9 emergency care practitioners, and 61 doctors. So what are the PTC building blocks? So we identify a hub, we identify a core group of dedicated, passionate people who can work as instructors, need not necessarily be a specialist. Anybody with knowledge and sufficient passion can become an instructor. And then we collaborate with various potential stakeholders. Like in my case, I collaborated with the Eastern Cape Department of Health, WSU, corporate partners. I interacted with family medicine, anesthesia, surgery, and so on. And then our motto is to provide knowledge to those in need. We don't restrict the course to doctors. We really go forward and invite clinical associates. We ask trauma nurses or nurses in the peripheral hospitals to come forward and join us. So there is no restriction to a certain group of professionals. And we also believe that satellite centers are key to establishment and sustaining such program or activity. And last but not the least, you should have a philosophy that should be working for you. And what is our philosophy? It is the philosophy of Ubuntu. I am because where you are, or I am where because we are. So here, what I want to say is that this has been not a very easy journey. It has not been very difficult either, thanks to the fraternity, thanks for the collaboration, thanks for the partnership. So yeah, I think we will carry on relentlessly, pursuing our goals in the years to come, thanks to the partnership that I'm having partnership not as just as establishments, but as individuals. That is my biggest strength. Thank you very much.
Yeah, thanks very much, Dr. J, for sticking to time. And I think the message is very clear in terms of impact and innovation, in terms of capacity building for clinicians across the province. And I think this is one of the right steps in, in the right direction in the province. The next speaker, is Dr. Undusana, who is going to be talking to us on developing an evidence-based instrument to guide transfemoral prosthetic prescription in South Africa. I'm sure we are all delighted and waiting to hear what you have to share with us. Oh, okay. So you can come, don't worry. Oh, yeah. Sorry about that.
Thank you, Chair. Chair, Professor Mbongozi has 2 PhDs, so I have no right to start before him. Please. But thank you for the honor, Chair. Let me proceed on the protocol that has been observed and greet everyone who's in the room. We were chatting with Professor Mbongozi that we're so lucky we're in the graveyard shift. So whatever we say, no one will question. Most of the people are sleeping. So I'll browse very quickly, Chair, on my presentation. Chair, before I indulge your guest today, I'm the head of department of a small department in the faculty, a relatively new department. And our dean prides himself that our department is led by young people. And I have a bunch of intelligent lecturers. And one of those lecturers will be presenting here today. And they are doing quite some good work insofar as prosthetics is concerned. Our profession, Dr. Mbongozi will translate for me. Our profession is not widely known, but being in this room, we all know what is an amputation. And the profession itself is a young profession in the country. And some of the things that one might assume they are there and they're available, they are not there. And as such, that's where I got the opportunity to do my PhD in developing a guideline for a transfemoral amputee. Now, this guideline was to, or is to be used to lead a practitioner in terms of how do you determine that this amputee is a suitable candidate to get a prosthetic leg. Now, I don't want to go into details in terms of the complexities of determining. So from a layman's eye, it may seem that any amputee is suitable to get a prosthetic leg. But that's not the case. There are many elements that go, or many factors that go into determining if an amputee or a person with an amputation is a prosthetic candidate. So for the past 6 years, I was exploring that, developing that tool, and one of the complexities was that in the country, we do not have a standardized protocol that we use as practitioners in the rehabilitation sector. We tend to use tools that we borrow either from America or the UK, Now, me being from Ecala, I'm always context sensitive. And I'm so happy that today all that has been presented here are innovations and some practices that are being done in Mthatha. And WUSU prides, sorry, not WUSU, sorry, forgive me, please. Walter Sisulu prides itself by being a contextual sensitive university. That's why we have successful programs. It's a pity that Professor Derek has left. We have successful programs that we continue to develop. The pioneer is here, Professor Mfenyan. His dream was that this university should work for the people, with the people. And I think that's what we do. One of my lecturers will be presenting here about an actuator foot that was presented by a professor here, and he showed that we are developing that food for the people. It's quite an expensive food. We'll need millions to fund it, but we believe that the province will be able to fund us. So, coming to my study, so like I've said, we had issues with equity. So equity is that if you go to a orthotic and prosthetic clinic, we have backlog when it comes to people getting their prosthetic legs. Now, without that screening guideline, it then relied on people's either expertise or the mood of the day for a person to get a prosthetic leg. Now, we could not control that. Now, as someone who's heading a department that's producing students, I had to make sure that what we do is evidence-based. And these students follow evidence-based when they go to practice. So my tool was, or is mainly focused on equity and ensuring that we standardize how we prescribe these prostheses in the country. Now, like I've said, there's no unified national policy, and also the decision, there's variability in the decisions, and then that risk equity. So you find that most of the amputees or persons with amputations in the Eastern Cape, they go to Western Cape. And it is quite a shame that that should be the case, but because of capacity, yes, we have made strides. I should acknowledge the great work that the department has done over the years. We've even now started an innovation where a person can come today, we directly laminate a socket, they get a prosthesis today. So unlike in the past where they would have to wait for weeks and weeks and weeks, but now we're moving towards making sure that person comes today, they live with the leg. Because you can imagine if a patient comes from Lusikisiki in the great rural areas, then they come only for assessment, and then they go back and then they come again for measuring. They don't have the money for that, nor the time to do that. So we're trying to move with innovation as well to make sure that we move towards direct socket lamination. You come today, you leave with your leg today. Now, as I've already mentioned, so the aim of my study was to develop an evidence-based guideline to guide transfemoral prosthetic prescription in South Africa, not just in OR Tambo, but in South Africa. Prof. Mkhacha said, WUSU leads and WUSU lives. And I'm proud to say this will be coming from Walter Sisulu and will be used nationwide. In fact, SADC-wide, not just nationwide. So those were the objectives of my study. So firstly, I used scoping review to really justify that even if you go to literature, you won't find this particular guideline in the third world countries, no, not just in SADC, but in the third world countries. And the second element, or the second phase of my study was to then do a qualitative approach where I interviewed all the professionals that are healthcare professionals that have to do with amputation. So it was your surgeons, your physiotherapists, occupational therapists, prosthetists, and social workers. And then in the third phase, it was the consensus survey. So based on what I'd received from literature and also from the interviews, the qualitative interviews, I then formulated all of those and took some of the existing tools which are adapted tools which are from America and all the first world countries, and tabled up a list of variables wherein I then sent those to the healthcare professionals to say, which of these variables do you agree that are important to consider when you prescribe a prosthesis? Now, the most important thing was to make sure that the context is engraved in those variables. It's not just variables that are commonly used, but to make sure that we focus on our context. And then lastly, it was to then develop the tool, which all four were achieved. The conceptual framework, I use the ICF. I'm sure some of us know what is the ICF, but it's just a guiding document insofar as rehabilitation is concerned. But that was my conceptual framework to make sure that I work within a guided space. I've already spoken to the methodology. I will not repeat that, but that was phase 1, phase 2, phase 3. Now, the key findings from my research, just to mention a few. So one of the things that I found was that prosthetic prescription is not just about physical mobility. At face value, you think that giving a person a prosthesis is all about walking, but it's not all about that. I'm sure most of us have used external devices. To use an external device is not just, for example, a cell phone. We use iPhones, Androids, what. We have got preference. And that cell phone needs to be able to do what we want it to do. Sometimes people change cell phones every day. So that also apply in some of the things, like serious things like a prosthesis. But getting a prosthesis is not just about making a person walk. It's about the quality of life of that person. It's about reintegrating this person to the society. It's about giving this person dignity, making sure this person is a father or a mother again, or is they're able to go on with their childhood activities. So there's more to just getting a prosthesis, and that was highlighted. And for me, it was beneficial because what then this means is that with the knowledge that I have, it will be shared amongst my department, and then we'll be able to produce students who better understand the theories behind prescribing a prosthesis. Now, some of the variables that I felt are also important to highlight that can lead to a person not getting a prosthesis was cardiovascular fitness, residual limb condition. Also, I want to thank some of the surgeons that have come forth to work with prosthetists during amputation, because amputating a limb is not just about amputating. And we've struggled, we've come a long way as a profession. I used to work at hospital 10 years back, and I had to force my way, because if the amputation is done badly, this person can never be able to walk again. But if we work together with a surgeon and I try to advise on the height and how the amputation should be staged, and what to preserve, because for me, 3 months down the line, this person will come to me with the hope that they can walk. And if the surgery was performed poorly, then it's a problem. We've seen many cases where we had to go back and beg surgeons to say, this person cannot walk again. Yes, they are fit, we have assessed them, but how this surgery is done, can we at least do some amendments? And through that, we've been able to work quite well with surgeons now. My lecturer was passionate about that. Ms. Mkibantaka is there at the back. We always hand her because she's got a big smile. And mobility potential. So what we always try and make sure is that people don't use wheelchairs for a prolonged period of time because that inhibits their potential to walk. So whenever they get amputated, we try as much as we can that it doesn't last more than 3 months before they get a prosthetic leg. And again, the department has also ensured that they try to reduce down the list in the Eastern Cape to make sure that our people get services. And then lastly, or second last, but just the challenges generally that we face, which I think we're well aware of because they are quite similar when it comes to healthcare, is the rural access barriers. And as a university, we have tried to engineer some of our programs that we send our students to the field, and the dean is on our head to say, we're not doing enough in terms of sending our students to deal with rehabilitation issues in the rural areas. So we are also trying to ensure that we remove these barriers and make sure that people even in the rural areas, they're able to get access to prosthetic legs and all the other rehabilitation services. And then I've spoken to this one, transport and financial constraints. Somewhat, there's an interrelationship between disability and poverty. We always see people who cannot afford not the services themselves, but to come and get the services. And that's why the government has got disability grants and everything. So as a department and with my research, those are some of the things we'll try and work towards ensuring that we're able to assist them. Yeah. And then the significant areas that were produced by the study. So the guidelines are going to support equitable prosthetic prescription. So this will ensure that we prescribe based on evidence. So I will not dwell on evidence-based practice. And then we'll reduce inappropriate prosthetic allocation. So when you prescribe a prosthesis, there are certain variables that you depend upon, and we classify people based on their activity. So if a person is either a K4, so someone who's highly active and someone who's less active are not classified the same, and the components that you give to those two people are different. So now that we have a guideline, we'll then be able to streamline those people accordingly. And then improves resource utilization. So one of the things we're passionate as a department, I think also Prof. Apalata touched on that, it's pediatric prosthetics. We try as much as possible to invest on pediatric prosthetics. We've got one of our lecturers who's heading that, and she has done quite some good work on that. Ms. Mgwili Kekani, so she deals with prosthetic pediatrics. And then also, one of the vacuums that we have in prosthetics and orthotics is the absence of policies. So this research will also assist in the development of policies. And then the draft guidelines, just to highlight that they're comprehensive inpatient assessment. We'll look at the potential functionality of the patient, and then also aids in multidisciplinary decision making. One of our problems, again, that we were confronted with, not now, because we were working on those things, was that there was no communication within the multidisciplinary healthcare practitioners, where a physiotherapist wouldn't know what a prosthetist is doing, and a prosthetist wouldn't know what the surgeon did. So that discord was not beneficial to the patient. So when you have guidelines that can connect and we can see what we're doing to this patient, it benefits the patient, because that's why we're here, to make sure that patients get maximum benefit from the services that we render. And also, I've touched on this one, early rehabilitation planning. And then the original contribution of the study, it was the first done in South Africa, and it was contextually based, not just for the Eastern Cape, but for global South countries, because we share similar problems. And then, like I've said, it will also promote evidence-based practice. And then, in conclusion, evidence-based prescription is essential. I can't talk more on that one. In our profession, it's only recent that we had colleagues graduating with MSc. I think it was 5 years back. And also we've just recently had one of our colleagues as well graduating with PhD. So the profession itself, when it comes to science and evidence, is very young. And as a university, we've got in the department, I think more than 4 colleagues who have registered for their PhDs, because we want to ensure that we advance evidence-based practice and make sure that our students as well understand what is evidence-based practice. And then the guidelines also will improve on the fairness, efficiency, and patient outcomes. And then lastly, the study will contribute to their rehabilitation science at large. Chair, I think I should park here. Thank you.
Thanks very much, Doc, for the good work you are doing. Dr. We'll call him future professor because he's one of the very few that we have 2 PhDs in our faculty. He's somebody we are very, very proud of. He's a true alumnus of Sisulu University. He completed his MBCHB, MEd, as well as first part of the PhD in Sisulu University. And currently acts as the head of the academic head for Department of Obstetrics in Nelson Mandela Academy Hospital and Sisulu University. It is my pleasure now to bring Dr. Bogosi to come and share with us just a bit of what he did to us completing his doctoral degrees. Thank you.
The guy who spoke and had presentations on ulcers and all this other thing, he's my former classmate. Please clap hands for me. Yeah, I taught him and Dr. Mpumlwana University life. So you can clap hands for me again. They are still putting up my presentation, but there's no time for jokes. I think I will take not more than 2 minutes greeting you. Good afternoon. Yes. We are still waiting. Yeah. Thank you. Okay, good. Yeah, let's just get to it. Yeah, the digital blood pressure monitoring and the correlation between central and peripheral blood pressure in preeclampsia. I'm Kolane Mbongo's, the one who was mentioned by the MEC yesterday. I must recognize my university, the Department of Health, SMRC, and Discovery Foundation for sponsorship. Preeclampsia is a deadly disease. It contributes to more than 500,000 deaths annually, that is globally, per year, of babies. More than 250,000 of mothers who are pregnant, they die per year because of preeclampsia. In fact, in South Africa, it is number 2 as the leading cause of deaths in patients who are pregnant. It's quite a bad disease. We need to study more about this disease. It affects the brain. Some patients will have seizures because of preeclampsia. It affects the heart, the lungs, the kidneys, the liver, hematological system, all parts of the body. Patients will come with stroke. Later on, that is a man, but there's a story around that. But yeah, it causes stroke. The kidneys will fail, Tingi. And again, sometimes the placenta will separate before time, what we call abruptio. And when that happens, patients, they bleed a lot. Their babies die inside. Their mothers sometimes die. So preeclampsia is quite a bad disease. So the question is, can we be able to pick up the complications of this disease before patients die or have severe morbidity? That is the question here. What we have as a form of diagnosis at the moment is what we call peripheral blood pressure, the one that you know from the clinic. So we measure that. But the problem with the peripheral blood pressure itself is that it does not correlate very well with the severity of the complications. So we have a problem with that. Specifically, some patients who come with a complication of preeclampsia, which we call eclampsia. Eclampsia is when the patient with preeclampsia starts fitting. Those patients, sometimes they'll have mild peripheral blood pressure, at times even controlled peripheral blood pressure, but they'll still fit. The question is, what happens in the central system when that peripheral blood pressure is normal or mild? If you can see, the peripheral blood pressure is what you measure on the arm, what is written BP. Then the central pressure is what you measure around the aorta or the vessels that are close by. Why the central blood pressure? Why the interest? It is because it reflects the pressure that comes from the aorta or the vessels, the bigger vessels, as opposed to the pressure in the peripheral vessels. Again, it reflects the pressure that goes directly to the big organs, the most important organs, your kidneys, your liver, your brain, and all that. At the same time, we have already done some work in Walter Sisulu, Nelson Mandela, when it comes to central blood pressure, looking at what we call arterial stiffness. Arterial stiffness is a marker of central blood pressure. If arterial stiffness is high, the central blood pressure will be high. So what we have found in Nelson Mandela, Prof. Namagoa looked at this in 2016 with his colleagues. He found that arterial stiffness is actually high in patients with preeclampsia compared to patients without preeclampsia. Dr. Meme followed suit. He also used a different equipment which we call endopart, where he also checked and saw that the arterial stiffness is actually high in these patients with preeclampsia. But we had a problem translating that information into clinical practice. What if it is high? Then what? Now, in patients who are not pregnant, quite a number of studies have been done somewhere else that have shown that central blood pressure is actually very good in predicting who is going to have cardiovascular complications in the future, especially if you compare it to the peripheral blood pressure. If you use the central blood pressure, you might sometimes predict that this patient is going to have heart attack in the future. This patient is going to have stroke in the future. So we wanted to see if we can use that information in patients who are not pregnant. Can we use such information in patients who are pregnant, who have preeclampsia? So the key question is, could central blood pressure explain the severe complications, such as eclampsia in women with only very mild peripheral hypertension? We did a cross-sectional study, a very big study, with 540 pregnant women between 2022 and 2024. It's one of the biggest studies that just concentrate on preeclampsia and central blood pressure. In fact, we could not find any of this magnitude in the world. Whilst we're trying to find this comparison, we were faced with a problem that we know what is peripheral hypertension. Once you have a BP of 140 on over 90 or more, that patient has hypertension. But what about central blood pressure? Now, we could not find good information from existing literature. So we needed to first determine what central hypertension is. We use some analytic methods, your linear regression analysis, your receiver operating characteristic analysis, and we had some correlations that we did to check the peripheral blood pressure against the central blood pressure. What we found actually is that the central blood pressure is actually lower. For you to be having hypertension, when you measure the central blood pressure, the BP must be 116/78 as opposed to 140/9. For you to have the patient to say he has got severe hypertension is 148/95. That was quite remarkable and a very good finding for us. As we said, in the literature, we could not find such information. That is, again, a very remarkable finding. So then we compared now the central blood pressure and the peripheral pressure. We found that patients with mild peripheral hypertension who have eclampsia, actually their central blood pressure is severely elevated. In one of the papers that we published actually last year, we then concluded, among other things, that the central blood pressure may serve as a better parameter for evaluating hypertension, especially in patients with eclampsia. Then when we managed to find that the central blood pressure is good at picking up these complications, we said, because the central blood pressure is connected to the heart, what if we add cardiac biomarkers to this, like pro-BNP, like high-sensitivity troponin I? We did that. We found that each component by itself can be able to predict complications. For example, with pro-BNP, if you use pro-BNP in patients with pre-eclampsia, you are able to predict that this patient is going to have renal failure. The sensitivity is as high as 93%, just using pro-BNP alone. Now, if you then add high-sensitivity troponin and elevated, central blood pressure, the sensitivity and specificity increases. I'm about to close, as they say, the pastors say. Yeah. So what does this mean in real practice? We know that central blood pressure can be able to assist us in picking up patients who are going to have complications of preeclampsia. But before we do that, it is standard practice as scientists that we must have these studies done somewhere else before we can enroll it. But we are confident that if it is done somewhere else in other big centers like ours, we will find the same finding. And once we are able to find the same finding, we might as well push to say, instead of using the normal peripheral blood pressure, why don't we use a better machine, which is central blood pressure? Usulit. Thank you.
Thanks so much, Dr. Mbokosi, and that you were quite, you're quite a character, really. You stimulated everybody that were, they were already getting tired, and I think everybody is re-energized now after listening to your talk. I just want to check if Dr. Michaelis is in the room. Yes, and Dr. Kala, please make your way to the podium. We need both of you here, and Dr. Kim, the head of the department. This is actually a collaborative effort of the pediatrics department at Frere Hospital, but very briefly, Dr. Michaelis is a senior specialist who had some initial training in Germany and has been working at Frere Hospital for quite some years now. Primary interest is in infectious diseases as well as neurodevelopment of children. Again, with her is the rest of the team. I think Dr. Thomas, who is the head of pediatric oncology at Frere, will equally be sharing the presentation. And she has equally been in the Eastern Cape for quite some time. Our primary area of interest is in childhood cancers. Dr. Kim Harper has actually is one of the pillars now at Frere Hospital. He's been there for how many decades now? I can. Yes. Yes, but he's going to provide support for his team. So please welcome. We're starting, Dr. Okay, over to you. Thank
Don't worry, there are three of us, but we're going to be the shortest, I promise. Afternoon, colleagues and friends. I'm Kim Harper, the head of the Department of Pediatrics at Free Tertiary Hospital. And I was going to speak as well, but we've got a shortened program, so I'm going to let my colleagues do the talking. I just want to introduce them briefly. Isabel Michaelis is a neurologist and a neurodevelopmentalist, and I work closely with her at the clinic. And Carla Thomas is our pediatric oncologist and head of clinical unit. They've just arrived, actually, because they've been holding the fort and seeing all the patients while they allowed me to come and listen to the talks this morning. So thank you to them. We've got 3 subspecialists at our hospital, and we function mostly with generalists, general pediatricians. So we're very privileged to have them and their rare skills looking after our children. So I wanted to just say that in these challenging economic times, it's really difficult to source traditional departmental funding for upskilling. And that means courses and conferences and such like. And they're really vital to keep people enthusiastic and keen and to allow them to develop their professions and remain knowledgeable. So the talks they're going to give is a really brief introduction and outline about innovative, out of the ordinary thinking that has enabled and enriched the services we are able to offer. And it's really upskilled all the members of our pediatric department. They're also going to showcase extensive collaborations and various organizations with whom we work to improve our and the world's understanding of various assets of pediatric oncology. So let me hand over to them. Isabel, you're going to start.
Thank you. Good afternoon, and thank you for the invitation. So the first slide, please. So when I came here in 2009, I started working at Freya, and I realized that there are lots and lots of children with neurological diseases. And there are lots of things which weren't there, which were there where I studied before or where I trained before. And the main problem was that there was no radiologist, that there was no EEG service, and also the psychologists were missing, which we had in Germany. And the previous dean, Prof. Lazarus, he once gave a talk about the Discovery grant, the Discovery Foundation grant, and said, please try and apply for it, and that's what we did. Oh, can I do it? Okay. Okay, and that was actually really, really fundamental in changing our service, which we could give to those children. Yeah, maybe I will just quickly, that you can see the numbers. When I looked at the POPD files, there are 20% of the children coming in are either coming in with a seizure or the diagnosis of epilepsy. And there are even more with developmental delay, school problems, and behavioral problems. So that grant really helped us to establish a good neurological service, an EEG service. There were 2 nurses or nursing assistants which went to Cape Town to the EEG lab there. They trained both for 3 months each, and then came back, and we were able to do good quality EEGs now, and we are still doing them. As we were in the grant writing, we applied, okay, so here we also could do a small study, and it really showed that the service is desperately needed, and lots of children are not treated well for epilepsy and seizures. And this has actually also been recognized now by the International League Against Epilepsy, where they are doing the IGAP EPI Act, where they try to reduce the numbers of wrongly or not treated persons with epilepsy worldwide. So as we were in grant writing, we did another grant, and this was then, we received that as well, almost at the same time. And that was a grant from the German government. It's a hospital partnership, and we choose the hospital with colleagues. I knew my former consultant was actually the project manager from that side, and that was actually really, really also very helpful. So it's an exchange program, and it's a cooperation over 2 years between those 2 hospitals, one in Germany, one all over the world. And but in this case it was us at Freya in East London, and the neuropediatricians were involved, neonatologists and neuroradiologists, and we were able to get 4 doctors that side to have a little internship in Berlin, and 4 doctors from Berlin came and visited us here at Freya. We also had a one-day symposium in Cinza about neurological diseases and what we see here, and we established Zoom meetings where we do case discussions, and we learn a lot from them, especially from the neuroradiologist, who is helping us to look at those MRIs we are doing here, and they say they learn a lot from us, so it's actually a wonderful relationship, and it's still ongoing even though the grant has finished now. Thank you very much.
So on to a bit of pediatric oncology. So pediatric cancer is rare, but we treat a vast array of cancers, and it needs a multidisciplinary approach, and therefore leads to great scope for researching and networking. So we've developed a few strategic partnerships. So one is shared care. We have weekly tumor board meetings via Zoom with the team at Red Cross War Memorial Children's Hospital. Not only them, there's also teams from various hospitals in the country which usually join. And in that room, we have peds surgeons, peds oncologists, radiation oncologists, and radiologists. And we really then can give our children the best chance at the best care. Likewise, we have weekly neuro-oncology meetings via Zoom, and then St. Jude's Hospital in the States organizes weekly meetings whereby units all over sub-Saharan Africa can join. Nationally, our unit has contributed to numerous retrospective and prospective studies which span germ cell tumors, nutrition, Hodgkin lymphoma, and neuroblastoma, and quite a few publications have come from these. And the staff at the Freya Pediatric Oncology Unit, we serve on quite a few national working groups of SAPO, which is the South African Association of Pediatric Hematology and Oncology. We've also collaborated internationally, and recently we were part of an Africa study on pediatric low-grade glioma. So pediatric low-grade glioma is a WHO global initiative for childhood cancer index tumor. It's a high potential for cure, and it's best treated in a multidisciplinary setting. The SIOP Africa team noticed that there was a paucity of data from low and middle income countries, and therefore we collaborated across the continent, and we managed to produce a paper for Frontiers. Now, all this is great for research, and it does benefit our patients, but at the cold face, you have a mom and a dad with a child with cancer, and we really need good psychosocial support. So we have also collaborated with NGOs, and without their help, our work would be near impossible. So we have collaborated with CHOC, Reach for a Dream, Wings and Wishes, Cancer, and the Devon Fern Foundation, and they really make our lives, and more importantly, the lives of our patients, much easier. Thank you.
Thanks very, very much. I think we have, I'm sure there will be 1 or 2 engagements at the end of the session, and we'll move swiftly to our last presenter for this session. I'm going to call Dr. Shaoli to share a talk with us. She's a senior lecturer in the School of Biomedical Sciences where she teaches histology to undergraduate students. She's in area of research is focused largely on traditional medicinal plants, where, with specific focus on assessment of efficacy and toxicity or safety in animal models. And I'm sure she's going to share some exciting information on the progress of her work on this particular research niche area. Thanks very much.
Thank you, Program Director, and good afternoon, colleagues. I am going to share a path that I walked through in the development of a prototype from a medicinal plant targeting another optional therapy for the management of tuberculosis. Developing a new therapy or proposing a new therapy from medicinal plants, one would ask, while we have our current TB treatment that is prescribed to our patients, why now? Why medicinal plants? It is because of the challenges that we all know of the current TB treatment. So the whole work of moving towards now of developing this prototype started with identifying a problem. Or there is a problem with the current TB treatment. There are avenues that are being explored in as far as how can we meet this TB treatment that is currently on. We know a lot of vaccine developments are going on with promising candidates vaccines. But then we took, myself and my group from the TB group in the School of Biomedical Sciences, we took a different angle. And then we looked at what alternative can we think of situated in the Eastern Cape, where there's a lot of medicinal plants, where we read about researchers coming from all over the country, even from overseas. They come and study our medicinal plants while we are still here. So there was a lot of thinking. Then we came with an idea. Let us explore from the medicinal plant, what is it that we can bring to the fore to augment or maybe to bring a new therapy towards the drug resistance that we are seeing. Then we started with our IKS holders, the herbalists and the traditional healers. These are the people that know a lot about medicinal plants. They treat our people out there presenting with different ailments. And we know that as Africans, or Africa, our people use medicinal plants alongside the Western medication that we get prescribed by clinicians. So we went to them, and then we hold some interviews, and of course we got good information about the medicinal plants that they use. The whole work started to investigate the beauty of the medicinal plants. There were many of them that we studied in the team, but we came up with one plant which was giving us what we had proposed. We actually did not, our interest was not to fight the Mycobacterium tuberculosis because we know it is very manipulative, learning from what it does to the current TB treatment. Then we thought of, let's look at the cell that is actually, not mostly, is the one that gets infected by the bacilli in the lung, the macrophage. Then we said, let's see if we can actually maintain this cell in a proper, resilient phenotype that can actually now be able to degrade this back. So we now moved on with this beautiful herb. It's called Umvutusa in isiXhosa or Sanicula elata. We were just doing good science in the School of Biomedical Sciences. A lot of work has been done. I'm just sharing some of the biological assays that we did, the cytotoxicity, the immunomodulatory, which was the key thing that we wanted to immunomodulate macrophage, and of course some of the antioxidant activities and many more that we did. We went further now to when we are getting the positive results. We were interested to see what is it that is working in the medicinal plant, and then we did a lot of work in chemistry to come and find what is it that is working. We did the fractions, about 5 fractions of the plant, and of the 2 fractions gave us the exact result of the crude extract that we did. So this is the whole work that we did, and we came up with identifying the 10 compounds from this medicinal plant. We repeated the biological assays again to move on. This is part of chemistry that we did. We identified about 16 phenolic compounds, and if you read, you'll find that these compounds are very good antibactericidal. They are able to immunomodulate white blood cells. They're antioxidant at the same time. So this is all the work that I'm sharing. There's still a lot that we did until the project was picked by research, the OTT, which is the Office of Technology Transfer. They identified the project, and they approached us, this project looks more innovative, then can we take it further? That's when now the whole work started. We were introduced to Spoor and Fisher law firm to start the whole process of disclosing on all the work and the technologies that we have done on the medicinal plant. It's a lot of work. It took us almost a year to work with Spoor and Fisher, requesting that, but we were passionate and very patient with our work, and then we moved on. After a year, we received a confirmation, or what they called a provisional, and by that time we were not able to publish. We were not able to do anything because the plant had to be protected. So after disclosing and going all that long process, we got this document that now could allow us to say, you are provisionally protected, now you can start with your publications, you can start with your presentations anywhere where you go. So we got this document. A year later again, now we got a full IP, which is the patent for all the work that we did, and that is now giving us now even more time to work without any fear that somebody would have read about our patent, somebody would have read about our manuscript somewhere, and then they can steal some of the technologies that we have actually done on the plant. So this is the patent that we have currently, and with this patent, it is the one that also now we used, we said we want to develop a product. Now we don't have money. Then we had to run to TIA. It's an agency that supports innovative projects in the country. So through the Office of OTT, we were able to submit a proposal of funding. We want now to develop a product or a prototype out of these medicinal plants. So we got the funding. We are busy now working towards the prototype development. We do not have the skill. We don't know how to formulate a medicinal plant, but we want this plant to be out there in the market. We want to be out there as it is, as a plant as it is. So we have approached CSIR. We are now working with CSIR towards formulating this product. Initially, we had talked about dry powder, herbal tea, like they do in the village, like they do our communities. But with more presentations, with more listening to people in the forums like this, then the questions will be raised. What about syrup? What about tablet? What about inhaler? Then we took that into consideration, and fortunately, CSIR is going to be able to do all the 4 products that we are requesting. We are in the process of that. Paperwork has been done. My HOD just need to sign that, and then we send the plant over to them, and then we get them these products. Above that, we now want to take, we would have a product now. We have moved to UCT again, tuberculosis drug accelerator in the Institute of Infectious Disease and Molecular Medicine. We have also presented ourselves there because we want now to test this prototype in the animal model where we are infecting the mice with the TB bacteria, and then we bring one of the products that we would have and then see if what we have observed in the 3 series of technologies that we have done, we are going to get in the animal model. It has been a very interesting and very long, but we are very passionate. We can see where we are going. So we'll be testing our prototype at UCT. I'm not working alone. I showed you the IKS holder, the indigenous knowledge holder, who is based at Port St. John. We work hand in hand. He is part of the patent. He is there in the patent. And now I am working with these inventors that you see here. We bring brains together to find solution and this product to be out there for people to use and to take science from the lab into commercial space. So thank you.
Thanks very much. I'm not sure if Dr. John and Prof. Shitness knew what was coming and they placed her last because she actually brought, this is true innovation that is coming from our, the faculty. And we hope that will go straight to encouraging results later down the line. I'm sure definitely we've got 5 minutes to engage, I'm sure. Let's check with our colleagues. And all the speakers, please, can you make your way back to the stage? Yes, Doctor, can we pass the mic to one of our colleagues, Angela, I'm sure. Yeah. Please, can we give any other person? Let me just recognize, okay, Doc as well, Dr. Mpulwane. We've had about 8 very brilliant presentations looking at development, Dr. Kokose and his team setting up a cochlear transplant program in Nelson Mandela Academy. And I'm sure people should be interested in knowing how they can refer patients from across the province to their team. Can I see by show of hand how many, okay, all right, yes. Can we start with Angela, followed by Dr. Mpumana, and then back to Ma'am Godini. Who's, all right, please. Angela first, yeah. Dr. Mbongosi, please, can you come over to, I'm sure there will be questions or now we can translate central pressure into practice in the various clinics across the province. Yes.
Thank you very much to all the presenters. My question is for Dr. Mbongozi. I'm wanting to know what are the costs of the additional monitoring versus the potential outcomes that can be prevented when looking at central blood pressure in preeclamptic patients. For example, what would be the number needed to assess to potentially prevent a complication? And how would this translate from a research context into clinical practice? Thank you.
Okay, thank you. Prof. Adelaide was interpreting for me as we were talking. Thank you. So, but the question is about the cost. That's what he said to me. I was telling him that you must not ask me a very difficult question. I have only one biological mother. But So the cost actually, yeah, at the moment is quite costly when you look at the machine itself as an isolated. So it costs around about 16,000, just the machine. But if you're looking at the prevention on a long-term scale, in that you will prevent patients will not go to ICU, which is quite expensive in the regions of 15,000 or so. You'll prevent deaths and all that. So in the long run, it becomes a bit cheaper. And again, then once it is enrolled at a massive scale, it won't be that costly. It will definitely be much cheaper. Yeah.
Sure. Was that the only question? I think. Okay. Second question, Dr. Mpulwane.
All right. Thank you very much, MC, for the opportunity. My question, the first one is to Prof. Aparat. You presented a slide which quickly disappeared, and on that slide you were looking at the candidates who will be graduating in this coming exam, that is September. And there is 9 or 11 of them, if I remember correctly. And what I noted is that there were majority of them, 3 of them, because others 2, 1, 3, only department which had 3 was Department of Obstetrics and Gynae. So my question was, in fact, is it probably just a coincidence, or are you shocked that Obs and Gynae is doing that way? Because we currently have 2 PhDs at once, so yes, that was just that in passing. Then my last question, Prof, probably will sort it out later on. My last question is to the last presenter. Is it because the Mdlavuza plant, the one we were discussing, it's a beautiful plant for TB, but I'm quite interested to see if it can assist in your pulmonary, because I guess that's what you're looking at, pulmonary TB, pulmonary tuberculosis. In the case of female genital TB, will it be able to assist, or you still have to go through some research and trying to see that? Because remember, for me, that endometrium is very important. So if it can assist also in the endometrium, I think it would be, for me, a very good research. Thank you very much.
Please just give a remark on that. Yeah,
okay, thank you, Doc. At the moment, we are pinning ourselves on pulmonary tuberculosis. Hence, you see some of the products, there will be the inhaler that the patient will just have to inhale. But it's a good comment. Maybe we can now look further into, because we know TB disseminates. It does not only localize only within the respiratory system. That's a future work that we can do. Thank you.
Good afternoon, everybody. Thank you to the presenters. Mrs. Makwedini speaking. Dr. Kokose, I'm coming to you. Unfortunately, you touched a very sensitive area for me. You say for a year, you have been sitting without an MRI that is in the MRI unit. Is that true?
Yes, almost a year without an MRI. The MRI machine in Mandela got damaged, I think, sometime last year, something with helium. And then instead of being fixed, we heard that the hospital is actually buying a new machine. So we have been in that waiting period up until today. I think yesterday I heard that it got delivered, but when is it gonna be installed, I don't know.
To be commissioned. Because
Yes.
I'm looking at these babies and that are waiting out there. Remember, the reason the hospital sent Professor Miataza to Germany and everywhere to learn about the cochlear implant and the model, and even us doing the very organogram that we're showing teachers and everything there. Because if you go to here at Frey, what is the name of that place where their cochlear implants come and get rehabilitated, They did not have teachers and everything. We fought for that organogram so that when we do this, we can do it fully for the province. Now I'm worried about MRI and MRI, guys.
Yes, everyone is. We are also worried. So
You have not been using the one at Frey.
Yes. So what we do, because remember, I think at Frey also they purchased a new MRI, and then there was now a period where we did not have an MRI in the province. But as soon as it was installed, actually, we asked Frey to use our patients to train the radiographers. So we managed to get a few patients scanned. And then another thing we did is we approached now the private hospitals and asked, if they can do MRIs for us. The reason we did that is because we had a funder. We found a funder who was going to pay for those patients. So we have about 10 kids that are planned to be done in MRI, hopefully in the next week. And then we start operating them.
Yeah, thanks very much, Dr. Kokose. I think it's good you brought this issue up, because if there is anybody that can fight behind the scene and get things done, that is the right person that is picking up that issue. So, yes, and again, next to her is our boss, Dr. Jakta as well. If you know those people, things get done quickly. So you are in the right position, right place to bring those issues up. Any last... All right. I think, can I hand over now to... Okay. All right. Okay. I think maybe we should just start from that side. That is Dr. Shauli, and we're grateful to you for the work you are doing and, advancing medicinal plant as a probable product for TB management in our region. Thank you. Dr. Jack Krishnan, advancing global surgery in the Eastern Cape province. So thanks very much for the beautiful presentation you gave. And Dr. Michaelis, for your pioneering work in neurodevelopment of kids in the province. Dr. Thomas, pediatric oncology is growing, and especially in the central region and perhaps the entire province. So definitely your expertise in this field is going to be called. Dr. Harper?
No, not me. I didn't speak.
No. It's a team. I'm going to give it to you. Yes. It's a team.
No, you do deserve. As the head of pediatrics,
yes. Dr. Kokose, thanks very much for stimulating us and again bringing a very important issue to this particular session. Future Professor. Yes. Yeah.
Thank you. I enjoyed your presentation.
Thanks,
and I enjoyed your witty season. Yes. Work should be fun, and congresses should be fun, not boring. Thank you.
Yes. Yes, please come. Dr. Prof. Apalata, please. Prof. Apalata, please, it's your turn. And thanks again for the innovative approaches into advancing research productivity in the faculty.
And the boot camps.
All right. Again, Doc, yes, please, Doc, come forward. That's, yes, Dr. Nduzana, thanks very much. Yeah, and I think that concludes our session. Yeah, I'll give it back to you. Yeah, I think we'll probably break for tea, and then we'll probably, can I, permission from the Associate Dean? How many minutes is the tea? 10 minutes. Okay, because we need to move straight to the last session. of the day. Thanks very much, everybody. Thank you.
No conversations outside. This is gonna be, but in case save the best for last. I've got the best team this session. Those of you who are standing outside are about to miss out. I think it's beyond the afternoon. Colleagues, good evening. The time is 16:26 now. We're due to start at 16:25. This is our third session of our day. My name is Tozama Dubula from the Department of Internal Medicine and Pharmacology, Mandela Mtata. Our lineup has got 4 presenters in the name of Dr. Kobani Tuswa, Dr. Lindy Wefaye, Dr. Ndumi Ngola, Dr. Yamkela Desamele, Mr. Zanotu Mokodlimbi, and none other than herself, Dr. Zuki Chafta. In the interest of time, colleagues, let's start. The first presentation will be from Dr. Kobani Tuswa, an ophthalmologist based at Frontier Hospital, which is titled Community Ophthalmology in the northern region of the Eastern Cape. He's going to share with us how innovation does occur even if you're outside of the laboratories in the rural parts of the Eastern Cape. Over to you, Mdlelang.
Good afternoon. Thanks, Program Director. First, greetings to my senior colleagues and greetings to everyone. I have to mention them because they are with us till this time of the day. Thanks for recognizing that even people from the dusty places of Queenstown can be brought to the light of what you call this place is London. Anyway, I'll be very brief because of time. You can see the heading there is close to what he talked about, but not exactly. Because I've been briefed that the time will be cut short, I tried to cut the pattern to the cloth I have so that in 10 minutes I can be out of here. But I should explain to you that cataract blindness is a big part of community ophthalmology. So I decided, because of time, let's zero into that so that we can be more precise. Essentially, community ophthalmology itself is promotion of eye health and prevention of blindness using community modalities or rural health modalities. And it serves us, we're in the rural area. But then, of course, because we are in a place that more on the outskirts, some people don't know, but I thought it's best to show that. The technology is hampering me. Otherwise, if the pointer can show us there. If you're looking at the northern region, that's the northern region we're talking about, those 2 district municipalities. That is the Krisan and Jokabi. And we're serving a community there that is a bit vast, not too many people, yes, of course, but the regional hospital we're talking about is the beautiful Frontier Hospital. At least we've got some glass house. That's better. Most importantly, what are we talking about? I'm not going to start now describing cataract. Everyone knows about it. It's one of the leading causes of blindness. In fact, it is the leading cause. 45% of all blindness is definitely cataract. We're looking at 15 million people that are blind, with 78 million moderate to severe blindness. In Africa, the situation becomes even worse because there's not many of us around. And of course, there's good things that are happening these days, the aging population, good. But yes, of course, that increases the burden, making it now more of a public health priority. Physicians, comorbidities like diabetes make the management more complex. We are calling it the new tsunami. We're calling it the new pandemic. But yes, of course, it makes life very difficult, especially in the community-based programs that we run in the rural areas. Why is it complex? Because the complications you get out of diabetes, they do need tertiary care. And the people you are serving in the rural areas were even struggling to assess that lower level of care. Now, when you need an intervention that needs tertiary care, that becomes a problem. Long time, the stats is out there, and there's been talks with plans and missions. How do we now tackle this global burden? People know very well about Vision 2020, which we are already way beyond Vision 2020. But I want to update to you that the statistics as made then made people to look at how can we tackle this. A benchmark of 2,000 per million population cataract surgeries was set to be able to eliminate cataract blindness at the time. And I want to stress this, at that time. And I want to stress the fact that that was not met. Most of the developing countries could not meet that, to an extent that the target was revised to 1.5 thousand people, that is per million population, which is now a lower target. But still, most of the South African public sector providers at the moment were still running at 800 million, at 800,000 per million population. So meaning that our cataract surgery rate is very low. Now, there are other places that are doing better. India, for instance, India has increased it dramatically. The number I put there on the screen is 4,000 cataract surgeries per million population. They are above that, but what helped that is thanks to NGOs that are coming up to work in the space, thanks to cross-subsidization of cataract surgeries by big hospitals like Aravind, LV Prasad, Agarwal's hospitals, where now Prof. Mpenyana is on a financial scheme, but JAFTA doesn't have that. So that cross-subsidizes the people who cannot have, and then by so doing, lowering the cost of surgery too much. The other important thing that economists have noted is that your high-volume surgery translates to low cost in the long run. So that's another thing that made it to be a better place. But having said that, as the country, we're still way behind. Now, in the northern region, we've got the place called Sabona Eye Center. I believe some of you have not been there. Just to put it clear, it's like a beautiful hospital within Frontier Hospital. It's a standalone building, two-story building, that was historically donated by the then Fred Hollows to the province. How is that unit set up? As I said, it's a dedicated ophthalmic unit, mainly for high-volume cataract surgeries. Yes, of course, it offers a comprehensive eye care. Fully equipped eye clinic, 2 consulting rooms, and lasers are all available with a 25-bed ward. Now, anyone from the province here, department? Maybe they are tired. Why I'm asking them, they are sitting there with people who are talking about bed occupancy. Time and again, we fight when we meet, because I tell them that my mission is to keep my ward empty. I admit today, operate on them, discharge tomorrow. For them, an effective ward should be the ward with a high bed occupancy. I think people who are running the wards know that, but that's not our mission. And I even said that in developed countries and also in private sector, cataract surgery is now an ambulatory surgery. They come in, operate and go. But in any event, we still have a beautiful center that I say underutilized with capital letters. With that setup, we should be able to increase our cataract surgery rate to meet the targets, at least where we could be able to say we are eliminating blindness within the northern region and beyond, precisely so. Why I say beyond is that that is an Eastern Cape property. It should be able to, I should be able to get patients from Statarem, Katkat, and wherever when we've got the systems right. I'm just going to touch how we use it at the moment that I believe we are almost there. And I should not forget our local cataract surgery rate with no staff as it is. I'm sitting at around 600 cataract surgeries per million population, which is slightly below the global South African one. And considering that the unit is only served by one surgeon, but that's where we are. On a day-to-day basis, we've got a dedicated cataract list every day, and then we've got that is more of also, it's more of a high volume one, and then we have another day for complex cataract surgeries, teaching, and other complex operations. Our situation is not as good, but in my liking, it's very good because we work as a unit. You don't have staff in theater, you take them from clinic, you go with them, you finish in theater, go down with them to the clinic. But I want to still send that big warning. Whenever you do those things and when people burn out, people won't understand when you can't do anymore. There's a shortage of staffing. Okay, what is our referral base? This is the main driving point. We have ophthalmic nurse specialists at our local hospitals, which is what I want to drive more. Glencree Hospital, Mbilisweni, All Saints, our surrounding smaller hospitals, where you know that those nurses can identify patients. When they refer them, you know that they're from a person who has a better knowledge, and it makes it easier. You operate on them, they go back to them to follow up. We're bringing a hospital on board, but this is the model I would love to push most. Where I once worked, as written in some of on the documents in front of you, they called it a funnel approach, where you've got more lay people out there, just people who can find a blind patient. As you come down, the level of care rises till the last point. But most importantly, we do a lot of additional surgeries trying to catch up with the numbers, especially your cataract blitz, helped by NGOs. I'll just mention Al-Imdad because at the moment, Al-Imdad is the one that is having an MOU with the Department of Health. On top of that, I will mention also the project we once got involved in, where through the South African National Council for the Blind, we call it Bureau, they gave free cataract surgeries. I want to stress this. Free cataract surgeries through the province. We operated about 400 patients in 8 days. That was 2024. I'm not going to hide behind the fact that the pilot itself came out of the assessment that our waiting list, I don't want to call it backlog. Backlog is a technical term where you need a lot of statistical analysis, but the waiting list by book at the time was estimated to be 10,000. The question is, how do we bring this down? We said, okay, put heads together. Let's showcase what we have. Let's bring them together. We did 200 at Frontier, and another 200 was put to be in Matsiganinga Zulu. Surgeons that were operating there, only for myself, Dr. Mbelwa, Dr. Daimane, and Dr. Yako. Yako, the retinal surgeon who was in Amtata, also not there because of crime in Amtata. So that project, as I said, it's pilot. We still had plans to make sure that goes further up. And Ismedics is still working hard to make sure that we see the realization of that, which benefits the broader community, to make sure that we still live up to the promise that we need to bring down that 10,000 waiting list. And I want to make a very important differentiation. A waiting list and a backlog are different. That waiting list is people on the book, but in our books at the moment, go to PE, go to East London. If you book as a new patient to be seen at the clinic, the dates are at the end next year. So we've got a very big problem of access to care. So there's people who are not yet in the book to be known to be waiting, who are probably having cataract. So we're definitely beating below the belt with 10,000 number. But in any event, we want to try our best. Before I talk of barriers, I want to tell you a story of my wife is not a health professional. She was at SPA and talked to this lady. This lady happened to be frustrated, running, and then, why? And then the lady said, look, I left my mom in the house, and she locked the mom in the house because she's blind, and she had to go to SPA and go back to the mom. And then asking, what do you mean blind? No, he's blind and is waiting, has been to, and then she came to tell me, and then we said, look, just bring that mama to hospital. We operated there, and then we have means to break through, disrupt the system, do what is necessary, because we cannot have an elderly locked in a room because he's blind. Now, as I talk to you, that lady is walking out there. I can't even recognize at the clinic because now she's walking around. I probably did operate the second eye a few weeks ago, which is, that's a good one. What are the barriers? These are general, but it's specific to me where I want to boast of Sabona that we need professionals. We need professionals. I don't even have medical officers. I don't think that's working smart. Well, of course, we need to expand this, not to be only at Sabona. Sabona is original, but we should be able now to these places I'm talking about to be able to go there and do a little clinic that reduces the traveling on patients. At the moment, we cannot do that. Well, of course, physicians, I want to tell you that we need to work together on this one. I am very, very concerned about it. I've got a young patient, I'm talking now practical work. Young patient operated both eyes, but that patient is blind despite operation because the proliferation that's there is making the patient blind. And we do not have the services, that is vitrectomy services, which is the tertiary service, to help this patient. So I feel bad, but the essence was to try and relieve part of that. But when you have diabetes, it's not just one problem. Of course, we do private services that are not affordable at the moment to the people that are even struggling to access the most basic services we give. Thank you very much.
Thank you, Dr. Tuswa. Indeed, an established community clinician. He started this as a student as part of the Rural Support Network. Your 10 minutes was long. Thank you, Mhlelanga. Now we're going to come to Dr. Lindwe Faye, a medical microbiologist and a postdoctoral research fellow within the unit. Presentation is titled Beyond Coverage, Community Engaged Strategies for Impactful TB Screening. Over to you, Dr. Moses.
Thank you, Prof. Good afternoon, everyone. I'll just tell a story. I'm not going to present, I'm going to tell a story because of time, Prof. But my story is about using the dashboard for the screening of tuberculosis nationally, which is the strategy that has been put to place by the National Department of Health to screen people for tuberculosis so that we can be able to recover those people that are a missing population with tuberculosis, but they are spreading TB in the communities. So tuberculosis is known as a highly infectious disease. We have a problem in South Africa. We are burdened with tuberculosis because of TB, HIV co-infections, and drug-resistant tuberculosis. So there is ongoing transmission that is really burdening even our healthcare facilities because we can't be able to manage it as we want to do. So we have challenges like we need to screen people, like to strengthen the screening programs, early diagnosis for case detection, and community responsive intervention to reduce transmission. Then why screening TB was introduced, as I said earlier on, that is for those people that are undiagnosed, late diagnosis, because they lead to ongoing transmission in the communities. Also, some deaths, they do okay. So in South Africa, large-scale screening was introduced to increase case findings, reach underserved populations, and accelerate progress towards end TB strategy, which is part of 1990 strategy for 2030. So here, I decided to have a look from the NICD dashboard for tuberculosis. So if you can see there, that is national. We can see those pink parts there, those are females, then the blue ones are males. So if you are looking there, we can see that males, they are not getting screened. But if you see the block below, they have a high positivity rate compared to females. Also, we'll think of, I think it's a long-term fatigue now because the screening is declining nationally. So it's almost the same thing even in the province. This is Eastern Cape, so we are telling the same thing. Then again, this is Alfrenzo. So in Alfrenzo, we can see that, okay, yeah, again, males, they are not coming for testing, females are testing, but the high positivity rate. So the trend is the same from national, provincial, and the two municipalities. This one is OR Tambo. So I chose OR Tambo and Alfrenzo because they are the most districts that are burdened with tuberculosis, and that's where we are doing our research as iWater Sisulu TB research. So now I'm just summarizing those findings from the dashboard. So we see that from the target, we are targeting 505 million, but we are still at 406,000. So the target that we have achieved nationally is 48.8. Then Eastern Cape has achieved, unfortunately, 37.5, which of the provincial target. Then TB positivity rates, national is 4.1, Eastern Cape is very high, 7.1, Alfrenzo 7.2, OR Tambo 4.8. Then I analyzed the testing by age and sex, so the highest testing is 22 to 44 years, which is, I'm happy because from our findings in research as a TB research group, we found that the missing population is economically active age group, and the justification was that they are not always available, they are at work. But I can see now from the dashboard that at least they are the ones that are testing. So also females are testing more than males. So if you are sitting next to a male, just ask the male, why are you not testing? Then again, provisional insights, Eastern Cape, we have a serious problem. I hope they will give you answers because they are transmitting tuberculosis and we love them, we don't want to lose them, they must go for screening. So Eastern Cape, it's highly burdened with tuberculosis, but we have moderate coverage. So it means we must pull up our socks and work strategically so that we can be able to screen more people. Then OR Tambo showed stronger testing coverage. Unfortunately, Alfrenzo, it's lowest testing, but there's high positivity. So it means now, according to the results on dashboard, we need to focus more in Alfrenzo and find out why there is this problem and be able to bring solutions. So now we decided just to do a conceptual shift from coverage to impact as the presentation topic. So traditionally, when we are doing research, we are doing diagnosis, we always focus on numbers, which is the coverage, then that gives us limited real-world impact. Now we need to improve on that. So we are introducing a community-based participatory research or community engagement model. This model is focus, relevance, equity, and action. Then it's going to give us good outcomes because it improves case detection plus sustainable change. Then the key principle here in CPPR, it means we move from testing people and engage with communities. We really need to find out from them, from their lived experiences, what is going on. Then also, community engagement will enable us to build trust so that if we have seen from my figures that there is a decline. That's why I said maybe it's long-term fatigue of doing the screening, or maybe they have lost trust on us healthcare professionals. Maybe there's this thing that we are not doing right. But by doing community engagement, we'll be able to gain their trust. Then also, we need, through community engagement or community-based participatory research, to improve health-seeking behavior, especially from our fellow creatures, which are males. Then CPPR principle here is that communities now, they are core researchers and knowledge holders. This one, it is very important. We need to know, even if you are not from TB, but those community people, they have knowledge that we do not have, that we can use to solve something. Then CPPR process applied to TB screening. So it's a foundation, which is trust and partnership. We'll engage with community leaders, community healthcare workers, local organization, then we'll build trust, which building trust now, I believe that it will increase the screening uptake. Then we'll see the rate of screening increasing. Also, we'll be able to co-identify the problem. Why male creatures, they are not coming to screen? So if we work with the communities, I believe that we'll be able to identify where is the problem. So as the communities will identify why men are not testing, the barriers, because there are barriers like stigma, access, and workload. Sometimes maybe our fellow men, they are not testing because of these things. So if ever we are doing community-based participatory research or community engagement, the problems become locally identified. We will not assume that they are afraid of injection. You know, males, they are afraid of injections. That is an assumption. But here we want to know from them, from their lived experiences as well, why they are not testing for TB while they are transmitting tuberculosis. So also we'll be able to co-analyze and interpret what is going on, which will help us to explain why uptake is low, why positivity differs, and lived experiences to data interpretation. So we'll be able to interpret data together, not the experts in the field, like the university researchers interpreting the data alone, but now it will be informed by community knowledge. Then we'll be able to do action and intervention. We'll be able to implement together targeting screening strategies, community-led awareness campaigns, because if ever we have the community on board, I believe that even the turn-up when they are saying Department of Health is coming to screen for tuberculosis, maybe if it is led by community, the turn-up will be very beautiful. So CPPR is action-orientated. Then community-engaged clinical governance model, because we are trying different ways so that we can stop transmission of tuberculosis. So now it will integrate a molecular diagnostic test, which is the one that is being used for screening. That is a NAT, nucleic acid amplification test. There also the dashboard information that we got, then the CPPR. So TB screening gaps are not only technical, they are social and structural. So we need the community on board so that we can be able to solve this problem. So the test that we are doing, which is called NAT, enables the scale, but community and engagement will enable the impacts. So if we have the community, there will be an impact in screening tuberculosis. So now the future TB strategies must combine technology, which is us, the lab rats in the lab, and community partnership, our people there in the communities, because we are going to get whatever we get in the lab, we'll be able to to make sense when the community, they understand what is going on. So now we need to shift from top-down to co-produced intervention. So top-down means it is me, the lab rat, who's going to the community and give them solutions and not knowing what are their experiences. So now I'm saying we need to shift from that kind of doing things and do co-produced interventions like working with the community. So why integration matters? TB screening camps are not only biomedical, they are driven by social determinants, health system barriers, and so on. So therefore, no single discipline can solve tuberculosis alone. We have tried, but no single discipline can solve tuberculosis alone. So now I'm proposing a multidisciplinary approach, which is the TB group. We have been doing that a lot now. So now it means is these disciplines, they are working in parallel, like human biology, we are working with them. We contribute independently. So now the output there is a strong technical solution because we are technical experts, but there is limited integration. Have you seen that there are more in medicinal plants are more on checking genomic mutations. So, but limitation here of using multidisciplinary approach, which is like what we are currently doing, does not fully address community realities because there is no knowledge from the community. It's only us, the experts in the university, that are doing decisions. So interdisciplinary approach now, we need to work together. We are doing that. But now there's still a problem there, that it's still largely driven by experts. As we have seen, Dr. Shauli, we have worked with clinical governance, but it is us who are still deciding. No community voice there. So now, transdisciplinary approach is the one that I'm proposing, whereby we are co-creating knowledge with communities. What it means now, it means it's the integration of academic discipline, community knowledge. Communities might become core researchers. We must not research on communities. They must be part of us in research. They must be decision makers as us because it is their life that we are working with. This aligns with CPPR principles, which are shared power, co-production of knowledge, action-oriented outcomes. Then how this moves gaps to impact, the gaps that we have identified. So without integration, the testing will remain low. Our male fellows, they're still not going to come for testing and they will be busy transmitting tuberculosis. Then, but with transdisciplinary approach, so now the screening will become targeted because we will know for each community what is the problem. So now we'll have a tailor-made kind of a solution for each community. They will trust us because it will be our thing, not my thing, not their thing, but it will be our thing. It will also be sustainable. So the pathway that I'm proposing is that it must be the data, disciplines, community will make better uptake, early detection, and transmission of tuberculosis will be reduced. Then in conclusion, my presentation has demonstrated that there is multidisciplinary strength whereby we are using lab and data systems. Then interdisciplinary integration, whereby now we have epidemiology, which is us in the lab, and the other disciplines, which is social sciences. Then transdisciplinary impact. It means community-engaged TB control. That's what we want. Then the results will be a community-engaged, transdisciplinary clinical governance model for TB screening, which is what we are working on now to develop as a TB research group. Then lastly, my question will be, are we truly reaching the populations most affected with tuberculosis, or are we simply increasing the testing numbers without meaningful impact? This question challenges us to rethink how we define success of TB screening programs. Success should not only be measured by number of tests performed, but it must also be about equity research, or equity reach, trust, earlier diagnosis, reduced transmission, sustainable public health impact. Then I thank you.
Dr. Fai, I agree with you. Men are a problem. I've just asked the two men next to me why they are not testing. They haven't told me. Yeah, I think she's driven the point very well that prevention is better than cure, and we need to look at community-based engagement projects. Let's quickly go to the third presenter, Dr. Ndumi Ngola, an obstetrician and gynecologist based at Frere Hospital, who's slowly rising up to be a very big thing in cancer management, especially early detection. She'll be presenting to us on advancing the call to action for elimination of cervical cancer. Over to you.
Thank you, Chair, for that warm introduction. Good afternoon to everyone, all protocol observed. My talk is titled Advancing the Call to Action for the Elimination of Cervical Cancer. I think we can all remember that WHO in 2018 launched a call to eliminate cervical cancer by 2030 using 3 pillars, 90, 70, 90, that we'll talk about. So cervical cancer is a public health problem. It is the 4th commonest cancer in women. It kills a lot of women, and 94% of those deaths are in low middle income countries. Women living with HIV are 6 times more likely to get cervical cancer compared to the general population. And it is disproportionately affecting younger women. And as a result, 20% of children who loses their mother to cancer, it is due to cervical cancer. So this is why I think this is an urgent problem for us to solve. And the other thing is that it is a problem that can be solved because it is a preventable and a curable disease when diagnosed early, preventable through vaccination and screening and treatment of pre-cancer. It is one cancer that we can eliminate, and WHO had recommended 3 pillars for elimination. The elimination is defined as 4 cases per 100,000, and currently in South Africa, we're sitting at 33 cases per 100,000. So these are the 3 pillars that I've been talking about. They were launched in 2018 as a form of a strategy to eliminate cervical cancer by WHO, where they say by 2030, in all the countries, 90% of age-eligible girls should be vaccinated. 70% of women by the age of 35 and 45 should be screened for cervical cancer using a high-performance test, meaning using HPV DNA testing. And 90% of those who screen positive should be treated, and also 90% of those who are diagnosed with cancer should be treated as well. So bringing this home, in East London, from our gynae cancer database, GCRC SAMRC database, when we looked at our data from 2017 to 2024, you can see how many cases of cervical cancers we had. I actually say if we can eliminate cervical cancer, there'll be no job for a gynecologist. And that's probably what we should aim for because it's possible. And the one thing to highlight about those cases is that 80% of them presented as stage 3B or more. When I sit in as a gynecologist at Frere, it is so rare to get a patient that you can operate an early cervical cancer in public for a curable intent. Most of our patients, we are diverting them to radiation oncology because they come advanced, and that is the 80% that I'm talking about. So what are we doing to advance this call to elimination or to accelerate to elimination? We have been involved in some research projects looking at ways of making, because as I've said, this is a cancer that can be prevented through vaccination. We know that we've got a school-based program for that, which was launched in 2014 by the Department of Health. Our responsibilities and as facilities is to screen women. So one of the ways that we think we can screen women better and have better coverage is to do a single visit screen and treat, which reduces loss to follow up, because you will test a woman today with HPV DNA test, you get the results on the same day. So that is your alternative to pap smear, and you offer them treatment on the same day. The treatment is offered with thermocoagulation, which is a handheld device, which offers an opportunity for task shifting because it does not necessarily need a doctor to perform the treatment. Even a nurse can do the treatment. It is cost effective for the health system and for our women. Most of our patients, they don't come back for results after screening because they do not have money. They get 350 per month, and if they went to the clinic to screen this month, they're not going to come back next month for screening because there's another priority to be taken care of. So we lose a lot of women who are not coming back for their results. Currently, we are seeing a trend where we have patients coming in with advanced cancer, and when you ask them, which is unlike what we used to get in the past you used to ask a patient, have you ever had a pap smear, and the result will be no. Now they've had a pap smear, what were the results? It was a long time ago. You go and track her, it was in 2022, it was a high cell, she never went back. So if we embrace approaches like screen and treat, we are able to reduce that loss to follow up. The other thing that we can also look at is HPV self-collection, and especially if we're pairing it with a point-of-care testing, where a woman tests herself at home. You did hear yesterday Dr. Pillay, Prof. Pillay talking about the till wand that they've got in the US. But even here, we've got an opportunity to offer women an HPV self-collection. And if we use a point-of-care test, then that woman is able to get her results on the same day, and then she can be treated. We also, as a research unit, are also looking at options of HPV therapeutic vaccines and as ways of offering better alternatives to treatment. So I'll just go briefly to the research work that we've been involved in. One of the studies that we did is called the SESTA study. Most of you have heard a lot about it. It was a WHO-funded project. It was testing 2 algorithms where women are screened, and in one arm they'll be treated without triage, and then in the other arm we'll use VIA for triage. So this was a multi-country, multi-center study, but when it came to the Eastern Cape, we proposed a change in the protocol because we didn't want women to come in multi-steps. We were using a GeneXpect machine to screen for HPV DNA testing, which are available in all our hospitals in the country. So we had one GeneXpect machine in our research clinic that we used for testing women. And women were screened, and we screened 941 women in a period of a year. In our study, one of the inclusion criteria was women living with HIV. We had a very high positivity rate, as you would expect with women living with HIV, of about 65%. And women were triaged in both arms, but what I want to highlight with this slide is that in both arms, 90% of women were able to wait and be treated on the same day. And this is the benefit of having a single visit screen and treat instead of screening women today, telling them to come back in a month for results, and they never come back. So we also looked at if you are using a screen and treat approach, there's also concerns about, are you not going to over-treat patients? So we've looked at our data to see what is the best way of triaging. And we actually, from our data, we saw that if you use limited genotyping, it performs better in terms of triaging. And for anyone who watched last week the launch of the cervical cancer guidelines by WHO, they are exactly recommending the algorithm that we used. That now, if you are screening with HPV DNA testing, you do not have to perform a cytology and let the woman wait. When you get the results of the HPV DNA test, you can treat on the same day. So imagine now if you're having a point-of-care test that can screen for HPV DNA testing and you treat on the same day, the outcomes that you are going to get. So after doing that in a research setting, we also wrote a protocol for a pilot study where we went around the Eastern Cape with this to 6 facilities. We went to Nelson Mandela Academic, Mthatha Regional, Butterworth and Frontier, and 2 community healthcare centers in East London, Empilweni and Nontyatjambo. So our aim was to assess the feasibility of the same-day screen and treat, and to assess acceptability from patients and from staff. and we included women according to the screening guideline. We did put the upper limit for screening to 54 because we were treating with thermocoagulation, and we were worried that if we take older women, they might not be suitable because of the squamocolumnar junction, but I'm not going to go into detail into that, as they might be suitable for treatment with a LETS rather than a thermocoagulation. So this is the setup that we had. We've got the gene. We had a 4-chamber gene expect. We still have that. And the device that you see, the white device, is your thermocoagulation. So we treated with that thermocoagulation. So we've submitted an abstract for this pilot to the papillomavirus conference, which is happening in October. We're still waiting for an outcome. So what we did, we spent 2 to 3 days in each facility. In total, we screened 367 women. We had a positivity rate of 36%, and out of those that were positive, 101 were suitable for treatment with thermocoagulation, and we're able to treat them on the same day. So the one other thing that I want to emphasize with this study, is this study is how we saw how it improved access for women. At Frontier, in one day, we finished at 8 p.m. because women said, we've been waiting for our results. We never get them back. You are here, you're getting us results on the same day. We are not going to leave. We don't mind waiting. So it was us saying, no, we have to come back tomorrow, so we can't continue working until 10 p.m. And in one of the facilities, we had a lady coming in to screen in the morning. When we called for her results, we could not find her. Around 12 o'clock, she pitched. When she came, she said, oh, I'm here for the results, and they were positive. So that, what happened? Oh, no, I went to work, so I thought in my lunch hour, I'll come and get my results. She got her results and she got treated. She came at 7:30 in the morning, she got her test. 12:30, she came for her treatment, she got her treatment, she went back to work. And I mean, for us, there's no other way of improving access than offering people a service like that. So the other study that we're currently busy with, it was initially funded. The funder pulled out but did not take all the funds, so we're still able to continue with the study. With this study, we're just trying to test the clinical performance of a self-collected sample, if it's comparing it if it's transported dry or in preserved site. If you know currently, if someone is doing an HPV self-collected test, you must break the tip and put it in that 20 ml preserved site, which is very expensive, and send it to the lab. But in this study, we're trying to see if we send it dry to the lab and keep it for up to 7 days, will we still get the same results? So we're sending some specimens dry and some in preserved site. And if we prove, of which, I mean, looking at the preliminary result, it does look like it does not make any difference, is that we will not have to keep preserved site in the lab, which is quite expensive, in the clinics, if we are using HPV self-collection. Those specimens can just be transported dry, and that will be a huge cost saving for the government should we move to HPV self-collection. And the device that we used for the study, we chose the cheapest device, which is a Copen device. That Q-tip costs 20 rands, so which also will reduce the cost. So with this HPV self-collection, we are able to scale up screening and improve coverage. So in conclusion, with the 3 years left until 2030, innovative strategies like single visit screen and treat for rural poor communities, or even for urban, I mean, even in the cities, no one has time to wait when everything can be sorted in one visit. Should be considered. Introduction of HPV self-collection in the single visit algorithm should also be considered as something that can improve uptake, especially if you are going to test with the point of care testing, and also investing in point of care testing. And more innovations are needed for treatment. I mean, this is like one of the huge things in treating pre-cancer. When we screen women for cervical cancer, we're not detecting cancer, we are detecting pre-cancer. But all the types of treatments that we've got are quite invasive. It's either we are going to excise, cut a huge part of that cervix, which might have future implications for fertility, or we offer thermocoagulation, which is also, it's heat, but it's also an invasive product. And for years, people have been trying to look at other modalities like therapeutic vaccines. We haven't been successful, but the search is continuing. And we hope with, if we can get innovations like that, they would also make the work easier. Otherwise, thank you so much, and I would like to also extend an invite to our Gynae Oncology Congress, which will be held here in East London for anyone who has interest. Thank you.
I told you guys, save the best for last, Niazivel. Yeah. Unfortunately, I couldn't help Dr. Ndumina. I couldn't ask my colleagues to scream. Yes, sorry. I'll try and help next time. Yeah. Yeah. Innovation is coming left, right, and center. The quality of care we provide is improving every day. Now we've got hepatopancreatobiliary surgery unit at Umtata. Have I pronounced it well? Yeah. So the person who's leading that project is none other than Dr. Yamkela Desemele, a qualified general surgeon who's recently completed post subspecialty training in surgical gastroenterology in Gauteng, and he was prepared to leave the bright lights of Gauteng to come back to the Eastern Cape. Over to you, Dr. Desemele.
Good afternoon, everyone. Thank you, Prof, for such an introduction. My name is Yamkela Desemele, so I'm a general surgeon, subspecialist HPP surgery. I've just completed last year in 2025, July. Then I came back to Mthatha. I'm a product of Sisulu University. So I trained my general surgery in Mthatha, then I went for my fellowship in iYunivesithi. Yeah, so I think the opportunity that I've been given to come to this International Medicine Week to just present and see, like, in terms of the establishment of the HPP unit. So we cover both HPP and Apache I, but here is all basically talking about the HPP unit. Okay. So as part of the introduction, so HPP is a highly specialized unit requiring an advanced training, and it's basically influenced by many factors, like, for instance, we depend mainly on what you call it as a multidisciplinary management of patients, HPP, radiologist, interventional radiology, oncology. So basically in this presentation, I'll be talking about the assessment of the current situation, but where are we in terms of the establishment of this unit since last year, August, what have we done so far, and what is there that's actually challenging us. So initially when I left, so it was general surgery which was taking care of that. Then when I came back, so I managed to take over the unit, and I was given, hopefully by Professor Mulawa, so that I can proceed, like, to establish the unit. So the burden of disease is actually, there's a lot of burden of disease. Like, for instance, we see a lot of obstructive jaundice patients, they come at an advanced state. So these are the patients that we're mainly seeing in the eastern region of the Eastern Cape. So I will outlook what we have already provided so far in Nelson Mandela Academic Hospital. So when I came in, so I had to set up, like, for instance, we have a day, as we all know, that we have to have a particular clinic which was already established, which was very easy for me. Then we dedicated our focus mainly on HPP and Apache I, so surgery, like, for instance, taking care of cancer of the esophagus, as well as peptic ulcer disease, gastric malignancies. Then initially it was an open clinic, so I had to discuss with the district hospitals. Initially I had to send a message, that we are running this kind of a service, so we are happy that you can send any patient, you can call directly Dr. Desemele to come through, or you can send your patients. We run our clinic mainly on Wednesdays. So in SOPT for HPP alone, so we see almost up to 130 patients, not counting basically the Apache I
like unit, like we go up to 250 if we include those ones in a month time. So one of the key things, which is, as we have seen, like most speakers, so you cannot work alone, especially in the unit. So I had to establish a multidisciplinary team, which involves a lot of, like, for instance, number one, a radiologist, oncologist, ICU, pathology, anesthesia. So this is actually key, like in terms of managing this patient, because we deal with a lot of, once we have operated on these patients, we have a lot of morbidity, as well as mortality. So you want to make sure that before you go in, you are certain on what you have seen, as well as, like, for instance, whether you are good in terms of the CT scans or MRI viewing. So it's always comfortable that you have an opinion from other people. So this is so we also had to set up an endoscopic unit, so, like, for instance, in terms of interventional, which is basic for now, which is an ERCP. So, like, in the past month, like, we have done almost 113. Yes, we have some failure rate, which is at 20%, but 80% of the time we're able to manage, like, we manage to intervene as well as place stent on the biliary system. So as you can see that almost most of our patients, they are malignant-related strictures, up to 47 of the 113. Then some of them, they're stone diseases, So failure to cannulate, as I've said, that it's been maybe at the first attempt, you'll fail to go into the bile duct, but as you're proceeding, like on the second attempt, you'll be able to go through. So these are the interventional procedures as well, that the transarterial chemoembolization, like, for instance, with those patients with hepatocellular carcinoma. So it's also one of the diseases that we see quite a lot, with an assistant. So I was fortunate when I came through, then Dr. Odonkos, an oncologist. So we sit, like, in the meetings, we discuss, and then see what can we offer, like, for this patient, as well as I was also fortunate to have Dr. Mtimba, who's also the vascular surgeon. So, like, for those patients that we want to intervene, like, in terms of doing the taste, so, like, giving the chemotherapy, doxorubicin, go through the arteries into the tumor, like the feeding vessel, then we can inject. So we have managed to do 2 so far, which is quite a milestone for us, because no one is